Hello, everyone, and welcome to ADA's first virtual fall forum for professionals spotlight on maternal mental health treatment and research. My name is Astrid Masfar, and I am the Professional Education Manager here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's audio system by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. All participants will be muted by the organizer. You will also have the opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may be asked to read your questions aloud. If given the opportunity, the organizer will directly message you and ask if you'd like to be unmuted so you can ask your questions out loud. You may send in your questions at any time, and we will collect these and address them during the Q&A sessions at the end of the presentation. If you're seeking CE and CME credit, you will receive a follow-up email that includes the webinar recording and the link to complete the webinar evaluation. Once complete, you will be issued your CE certificate. I would now like to introduce ADA Senior Advisor for Professional Education, Barbara Campbells.
Hi, and welcome everybody. I want to make sure that folks can hear me.
Yes, we can hear you.
Everyone can hear me? Terrific. So first of all, and most importantly, thank you so much for joining us today. We're very, very excited to be presenting this inaugural fall forum. This year's presentation is on maternal mental health, as you all know. One of the most exciting things about our audience today, to me, is that we have about 50% of our attendees today are not ADAA members, and this is very much in line with one of the goals. So one of our goals for the forum today, one of the goals for the forum today was to present on the content of maternal mental health, of course, but another, I think, equally important goal for our forum today is to reach out to content area experts outside of our organization, content area experts who are interested in learning more about what we do and building some bridges between ADAA and our broader community of colleagues. So I want to, of course, welcome our members, but give an extra special welcome to our non-members today. For those non-members, I do want to talk just briefly about ADAA. We are a nonprofit membership organization dedicated to the prevention, treatment, and cure of anxiety and depression and the related anxiety disorders. And our focus is really across the board on education, practice, and research. ADAA's professional membership includes a range of mental health experts. They are focused on science, teaching, clinical interventions, and truthfully, most often a combination of those things. And they come from a range of mental health disciplines, including psychiatry, psychology, social work, APRNs, LPNs, primary care providers who have a particular interest in mental health, and so on. It's worth noting that no other mental health organization has the interdisciplinary base that we do, along with the specialized focus on mood and anxiety disorders. And we reach a broad range of our professionals and also, importantly, mental health consumers all year round. We do that through an annual professional conference that happens every spring. It's not too late to register for our spring conference. Also, we have professional webinars once to twice a month, a professional journal called Depression and Anxiety with the obvious focus. And in addition to that, professional blogs on our website, consumer-oriented blogs, and consumer-oriented webinars as well. In fact, our website is really quite active with 38 million consumers and professionals visiting it each year. So I do want to give you just a moment on what membership does offer you at ADAA, depending on your level of interest. So if you chose to join ADAA, you would enjoy year-long access to some of the continuing education programs I just talked about. We have a range of special interest groups and peer consultation groups. You can be included in the Find a Therapist database. I'll mention I happen to be included in that database, and it's a really wonderful way to broaden your reach as a clinician. You get discounts for the conference, and you can also get discounts for conferences and webinars put on by some of our partners. There's information on the website on clinical trials, support groups, and publications, and you as a producer of any of those things can have those activities publicized on the website as well. You would have free online access to our journal, Depression and Anxiety. Of course, you get to connect with others with similar interests and expertise, and it's a really wonderful place to call your professional home. So I know that Astrid is going to give folks an opportunity to ask questions, and I'm going to pause on that or pause any sort of questions on the organization itself, because I want to make sure we really get into the meat of our program. But you are, of course, welcome to type in any questions you have about the organization, and you can reach Astrid or me directly. So I was planning to introduce our moderator for the event at this point. I know she had to step away for an urgent situation. Astrid, is Dr. Yonkers back?
Yes, she is. So you can go ahead and introduce her now.
Wonderful. I'm delighted. So I will go ahead and shift over in that direction now. So Dr. Kimberly Yonkers is well known, I'm sure, to many, if not all of you. She is a professor in the departments of psychiatry, obstetrics, gynecology, and reproductive sciences, and in the School of Public Health at Yale. Her clinical position is chief for Yale New Haven Health Division of Psychological Medicine. And she has I'm sure you all are aware of her research career and productivity. She is currently Director of Research for the Yale New Haven Hospital Division of the Department of Psychiatry and Director of the Center for Women and Mothers, which is a research unit within the Department of Psychiatry. Her research group investigates the clinical course, etiopathology, and treatment of psychiatric and substance use disorders as they occur in women. And a major component of this work is the occurrence, assessment, and treatment of illnesses in pregnancy and the postpartum period, and as well across the menstrual cycle. In addition, Dr. Yonkers currently leads the gender study group that is reviewing and conducting text revisions for the DSM-5 text revision, and is the inaugural editor-in-chief for a new American Psychiatric Association online journal called the Psychiatric Research and Clinical Practice. Despite all of those activities, she has made time for us today, and we are delighted and grateful that she's done so. So with that, let me pass it along to Dr. Yonkers, who will be moderating today's program. Thank you, Dr. Yonkers.
Thank you very much, Barbara. And I wanted to introduce Joy Burkhardt. Joy is the founder, and she's going to be our first speaker. Joy is the founder and executive director of 2020 Mom. The mission of 2020 Mom is to close the gaps in maternal mental health care with the specific aim of ensuring that all women are screened for maternal mental health disorders by their obstetrical provider and offered a range of easy to access prevention and treatment options. Joy has been recognized for her leadership and vision with various awards. Most notably, she's received the Emerging Leader Award in Women's Health from the Federal Health and Human Services Agency at the Office of Women's Health. This year, Joy is being honored with the American Public Health Association's Outstanding Leadership and Advocacy Award for leading policy change in maternal mental health at a national and state level. So, do we have Joy ready?
I am ready.
Good. Everybody was able to see and hear me, I hope, the new technology that we have.
That's right. Well, it's a pleasure to be here, everyone, and thank you, Dr. Yonkers, for the introduction, and also to Barbara and Astrid for having me today. It's really a pleasure to help spread the word about these disorders, which impact up to 1 in 5 women. We'll get into some of that today with my presentation, but also our future speakers. So we're thrilled to be here. I'm with the nonprofit, as you heard, 2020 Mom. There's a picture of me. You can see me live, of course, on the webcam today, but it's a picture of my kiddos who are a little bit older now. I also want to share that I am not a clinician, but have really come to this work because of my career, almost 25 years in healthcare at a large health delivery company or health insurer. And I've really come to learn the difficulties and the complexities of the U.S. healthcare system, which has really driven my work and wanting to go deep in maternal mental health. There's a little more to my story too, which you can find out more about that on our website. But pleased to be here. Really excited about giving you an overview today of the landscape in maternal mental health, the national and federal landscape. But I want to start first with who we are, because it's always fun to start with a story and get you grounded in the work that we do and why we came to be. And I wanted to share that, interestingly, just like many consumer advocacy organizations, which some say we're little more than a consumer advocacy organization because we're also advocating for support for professionals in this space because it's complicated. But almost all of us in this space that also have a consumer advocacy lens have a story behind why we got started. And that was the case with 2020 Mom. We had a young junior league member. Many of you may know the junior leagues, that they do work in communities around the United States supporting generally underserved women and children. And there was a young junior league member that had just visited her sister who had a baby, and on the flight home she read an article in Self magazine about this mother and child who tragically had lost their life to undetected maternal mental health disorder, and we now know a bipolar disorder, which will be important for us to distinguish today in today's conversation, often mistaken as depression, and she tragically again took her baby's life and then her own. And that moved this young junior league member to share an idea for a new law in California that asked for hospitals to provide information at discharge about the range of disorders and any local treatment options, which is quite exciting. It was actually at the height of the budget crisis in California in 2009 when that idea was brought forth, and that bill didn't go anywhere. And instead, it was morphed into an awareness resolution declaring the month of May Maternal Mental Health Awareness Month. But there were quite a few families that gathered when that bill was introduced at the state capitol, including Raul Martinez, who's featured here, who lost his wife to maternal depression. And he said to the legislature in California, if only we had known that, number one, these disorders are real, right? Postpartum depression, etc. But also, if only we had known she was at a greater risk, which his wife was at a greater risk. And these are the words that he said over and over again as he testified. You know, the role of sleep. She couldn't sleep. Breastfeed, breastfeed, breastfeed. And we wish we had access to ECT. So really interesting stories that moved the legislature in California. That resolution that I mentioned that called for May being recognized as Maternal Mental Health Awareness Month in California, that bill about hospitals turned into a resolution, which is not a law, but instead really urging Congress or the state legislature to recognize something as important and declare the month of May Maternal Mental Health Awareness Month. And at the end of that resolution, it was actually our state senators that tucked in language that said, we heard such compelling testimony that we want volunteers, since the state doesn't have money to do this work, we want volunteers to form a coalition and convene multiple stakeholders and get to the bottom of why women aren't being screened and diagnosed. And this was just one of my favorite quotes about our work from the chair at the time, Lori Gregg of the American College of Obstetrics and Gynecology, just really pointing out that the work to convene multi-stakeholders is really important because this is a complex issue, and understanding the barriers as to why women aren't being screened and then later diagnosed and treated is critically important. So we started our work in California, but ultimately we named ourselves from the California Maternal Mental Health Collaborative to 2020 Mom, with the idea that by the year 2020, we will have really help set the ground stage for systems change, national, not just in California, and help to bring this issue up as even more of an emerging issue than it had been at the time. We are going to stay around past 2020, and we'll include a dash in our name to really represent vision for mothers and maternal mental health. So what's in the name? I wanted to share that we started out as the collaborative, and now we're 2020 Mom. And May, again, our names just slightly changed beyond the year 2020. But I also wanted to point out on this slide that there's a lot to know about the name of these disorders. And I wanted to kind of take you through a pathway of thought and why our organization uses the term maternal mental health disorders, and also why you'll hear lots of different terms being used. First, I wanted to point out that still some of us use that term postpartum depression to mean more than just depression in the postpartum period. And our organization and many others are really urging that the field move away from that term, because it can confuse not just providers, but also patients. What if they have onset during pregnancy of a range of disorders, which happens, the research shows, almost as often, new onset in pregnancy as in the postpartum period. We also wanted to share that the term perinatal mood and anxiety disorders is still often a clinical term that's used, though advocacy organizations at a national level in mental health have urged the field to stop using the acronym PMAD because of the connotation of mad. So there's a movement to move away from at least using the abbreviation, which is quite hard when that term is so long. And then I mentioned earlier that maternal mental health is somewhat being adopted more widely, so you'll hear that term. And then parental mental health, or perinatal mental health, which I know all of you know, means pregnancy through the first year postpartum. But perinatal and parental actually don't exclude dads. So those organizations that serve fathers, including our sister nonprofit, Postpartum Support International, who does a lot of great work training therapists and others in this space, are adopting that term perinatal mental health because they also serve fathers. So I always start out with my presentations with these core statements, and it helps people understand just how important this work is. So I like to say and start with, did you know that women in their childbearing years account for the largest group of Americans with depression? Did you know that postpartum depression is the most common complication of childbirth? Did you know that there are more new cases of mothers suffering from maternal depression each year than new cases of women diagnosed with breast cancer? Did you know that the American Academy of Pediatrics has noted that maternal depression is the most underdiagnosed obstetric complication in America? And despite all of this, despite the high prevalence and still all these statements, maternal depression and the range of disorders largely go undiagnosed and untreated. And that's why I'm here today to talk about why. What are the screening tools that are most often used, and how you can play a role in effectuating change. So just quickly, I'm not going to go into all of these, but I think it's important when we talk about screening to not only detect current symptoms, but also to know who's at risk. I'm not, again, going to go into these, but I do like to call out that very bottom statement here that says lack of practical or emotional support. And the reason that that's in red and why I like to call it out is that it's hard for us to effectuate change with these other statements in black, right? We can't do a whole lot about low socioeconomic status or whether a mom's a single mother, for example, but we can perhaps do something about lack of practical support or emotional support. So I wanted to start with addressing what are the validated screening tools, and I think my colleagues may be talking about some of these in their presentations as well, but wanted to start out with saying that the Edinburgh or EPDS, you might also hear it called the Edinburgh, is the most widely used tool in the perinatal period, especially by therapists. So those, I think many of you are therapists, this is the tool that you may look to utilize when you're trying to identify maternal mental health disorders or maternal depression. What's also good about this tool is it includes 10 questions, but it also can pick up on anxiety, which some argue the tool just below it, the PHQ-9, doesn't necessarily do well. Others say maybe it does. It doesn't sort of screen out for anxiety, but there's a specific question on the EPDS. The PHQ-9 is most often recommended by researchers and also most often used in primary care. So for our work, because we're trying to effectuate change and actually have providers like obstetricians screen for maternal mental health disorders, since they serve as primary care providers during pregnancy and now in the postpartum, even to a greater extent because of the American College of Obstetrics and Gynecology's new declaration about the fourth trimester and the postpartum period being a critical role for OBGYNs to serve. That PHQ-9 tool may be one that you hear your colleagues use most often if they're not just serving women in the perinatal period. So OBGYNs may be screening, we hope, right? Not just women in the perinatal period, but also those who are teenage women who may be suffering and those that are suffering through other life stages after the perinatal period. Hospitals and others may use PHQ-9 as well, more often than the Edinburgh. Also, as I mentioned earlier, well, I didn't mention this earlier, I'm sorry. I wanted to share that the PHQ-9 also has a shorter version, the PHQ-2, which many of you know, that has just 2 questions, which a lot of primary care providers appreciate, including obstetricians. And then because the PHQ-9, some state doesn't detect anxiety in a specific way, the recommendation has been by several organizations that if the PHQ-9 is going to be utilized, that the GAD-7, the equivalent to the PHQ-9, also be utilized in conjunction. There's also a GAD-3, a shorter version of that questionnaire. I also want to point out that there are 2 other anxiety questionnaires that go a bit deeper, and that's the PASS assessments, the perinatal anxiety, and I'm drawing a blank now on what the 2 S's mean, but that tool was created and is a validated tool. It was created out of Australia. And also, again, the EPDS-3, a shorter version of, it should say the GAD-3, a shorter version of the GAD-7. Why this is important, I want to share that a lot of women, as my colleagues will likely confirm, present first with symptoms of anxiety. So racing heart, not being able to sleep well, even when the baby is being cared for, and also intrusive thoughts, which are very common. There was new research that came out that indicated that 50% of new moms, including pregnant women, will have thoughts that are unwanted and sometimes can include fears of harming their baby. And so it's critically important that we start to detect these disorders. And often women may not think they're depressed. And so talking about being anxious is something that they actually like to use and can relate to more than depression. Anxiety, of course, as I mentioned earlier, is a precursor, can be a precursor to depression. And then finally, I want to point out on this slide that there's a movement to really begin to look at mental health history in addition to screening for depression and anxiety, really looking at who's at risk. So even if she's not suffering right now, might she be at higher risk? The U.S. Preventive Services Task Force, I'll talk a little bit about their recommendation to screen in just a moment, but they also have now come out with a recommendation to assess for who's at risk and that insurance companies should cover the assessment for who's at risk. There has been a questionnaire that 2020 Mom actually created based off of their research on who should be, or what are the risk factors for maternal mental health disorders, and that tool is on our website. There are other ways that you can assess for risk, not using a specific tool, but those questions, those 5 risk factors that the U.S. Preventive Services Task Force has identified, we have put into a checklist for providers to look at. So other really important screening tools, and again, I welcome my colleagues who are presenting today, also Dr. Yonkers, to talk about any of this to the extent that's necessary. But we're really a proponent because when we're looking at patient safety, which many of you may know that suicide is a leading cause of maternal death. The U.S. has the only rising rate of maternal death and maternal mortality of any developed country, and the highest rate of any developed country, and suicide is a leading cause. So if you're looking at maternal mortality and want to prevent maternal death, which I know all of us are interested in, you can't not screen for bipolar disorder. And the MDQ is the tool that's utilized to screen for those disorders. What we suggest and others suggest is that once you have a positive screen for depression, that then a woman, and actually a diagnosis for depression, that then a woman be screened using the MDQ to rule out bipolar disorder. And it's important because treatment pathways and treatment options need to differ. And in particular, we need to know and make sure that a woman isn't prescribed an antidepressant, which may trigger mania and lead to psychosis, which puts a woman at high risk for suicide and infanticide. I'd also just like to point out these other tools that you're going to start to hear more and more about. First is that many populations don't relate to depression, and those words can turn people off. I'm not depressed, I'm strong. And instead using screening tools like the sleep screening tools, like the Pittsburgh Sleep Quality Index. We know that there are sleep disturbances with both depression, anxiety, and bipolar or mania. That can be a really powerful tool to see if there is something going on, which women aren't going to push away. Adverse childhood events. Many of us know these screening tools are now being used more widely to detect prior trauma, which puts a woman at risk for these disorders. And then the City Birth Trauma Scale is used to screen for birth trauma. Again, the U.S. has the highest rates of maternal mortality, morbidity, and also then it's safe to perhaps make the assumption that higher rates of birth trauma, something that we should also be thinking about that can lead to PTSD. So again, quickly, just a menu of treatment-based options. I'm not going to go into this again, but want to make sure that those of you who are clinicians understand the range of treatment options and why it's really important. I'll touch on this in just a moment, but we know many women are fearful of medication more than ever for various reasons about how these medications might harm their unborn child or harm their children who are breastfeeding. For treatment preferences, we know that African Americans, Latinas, and Caucasians prefer psychotherapy over antidepressants. I just kind of hit on this. Interestingly, we find in the research that Asian American women are less likely to accept psychotherapy referrals because it's not culturally accepted by elders. It's more likely that they want to be secretive about their treatment and receive a prescription drug treatment or some other treatment that will allow their family members not to question where they're going, why they're getting therapy, etc. And again, I hinted at this already, but childbearing age women, now more than ever, we aren't seeing this in research per se, but we're really hearing this and seeing this online, that childbearing age women really don't feel comfortable often with medication risk. You can use your imagination as to why, like, is the FDA really protecting us, etc. And how do I really know that these medications are safe? And so that range of treatment options is important to consider. And those, I will also say, those who are finding it hard to find treatment and are really struggling with severe depression and anxiety, they're willing to try medications, whatever the risk might be, and will stop breastfeeding, are fine with potential risks to their unborn child because they're so desperate, perhaps suicidal. So what does the research say about how often women are getting the treatment that they need if they are actually screened? So I'm going to start with the screening rate. There was a study done by Cigna Healthcare. You'll see the citations there at the bottom that found, this was in 2014, but found that only 5 to 6% of women are being screened for maternal depression, 6% during pregnancy, 5% 5% during pregnancy, 6% in the postpartum period. We also know that of those that are actually screened for depression, that less than a fourth of all women will receive treatment, and we'll go into why that's the case here in just a moment. We also know that only 6% of women will sustain treatment. So what's going on? If you're like me, you want to know why, and especially if you understand the cost to society and the impact on children when mothers don't receive treatment, both the unborn child and the new infant. And there's lots of research, which I chose not to go into, and I think one of my colleagues may here in a moment, about the impact to children when these disorders aren't screened. So if we know all of these things, then why aren't OBGYNs or pediatricians and others screening for these disorders routinely? So what the research shows is that 44% of OBGYNs, and this was a survey that was conducted of OBGYNs, report that they always or often screened, but the research also showed that they aren't necessarily using a validated tool, and all of us know that you can't tell by looking, right? Especially if those that are really suffering, they might actually take more time to get dressed and put makeup on and make sure that their kids look like they're put together because they're trying to hide something. We already talked about the screening rates by Cigna, and those who don't screen in this survey indicate that they don't screen because they don't feel qualified. And we know that medical school curriculum and fellowships, etc., don't necessarily go into maternal mental health disorders. They feel like it's the psychiatrist, the other MD partners that should be treating these disorders and identifying them. It's not their role. They treat this part of the body, not this part of the body. We also know that there's not enough time, right, to screen and manage these cases. So if I do screen, and screening we know doesn't take a whole lot of time, it's more the management piece. If I screen, then what do I do with a positive screen? How do I make sure she receives care? My risk goes up for liability, right? If she doesn't get into care and I've identified that she's suffering. And then the big elephant in the room, again, why it's red and what we might have control over is, immediate control over, is that they don't know where to refer. We also hear often that there's no financial incentive, which we think is quite important. Pediatricians raise the same concerns in similar surveys as OBGYNs. The added concern they raise is that the mom isn't their patient. So they can't actually treat mom like obstetricians or PCPs may be able to do. You might also just check those asterisks later, and this PowerPoint will be available to you later on. So what's going on with families, right? We know women are still afraid to speak up, and what's going on around stigma. So they're often very confused about what's happening. Unlike other medical complications, doctors, OBGYNs, for the reasons we just heard, are not educating patients on the fact that this is the #1 complication of pregnancy, and they're confused about what's happening if they actually have new onset during this time. There's also the general stigma of mental health. We know that severe mental illness and the homeless crisis in the U.S. With our mental health population, like those with schizophrenia, that can be scary, and women don't think that that's not me. So, and I don't have a mental health disorder, and so this general stigma of mental health disorders can really get in the way of speaking up, along with that confusion factor. They don't want to appear ungrateful for their babies. They love their babies, including those with intrusive thoughts about wanting to harm or fearing that they may harm is the more appropriate term to use their babies. They don't want to appear ungrateful, and they don't want their babies to be taken away from them, which is a real concern and a real problem. We've seen this happen too often because of the mandatory reporting laws and providers not understanding who's at risk and who is not at risk, a critical distinction. They also don't understand the risks of their baby's health. So if they know that their babies are more at risk for developmental delays, they're more likely to take action. Again, why those two line items are bolded. We also really want to make sure all of you know that when moms finally do speak up, if they're not being screened routinely, right, when they finally speak up, often help isn't available and they're sent through this vicious cycle, which is here up on the screen now. So this problem of very little awareness, screening rates being still too low, and a shortage of treatment options can really make this problem a hard one. So what do our trade associations say, or our professional organizations say? The American Academy of Pediatrics has been the first of all of the trade associations, provider trade associations, to recommend that pediatricians ask women how they're feeling. That was part of the Bright Futures those were part of the Bright Futures recommendations. And the AAP has long understood the impact on child development. So we want to really lift up leadership of the AAP. The American College of Obstetrics and Gynecology says now recommend screening. In the past, they did not recommend screening because screening didn't lead to treatment for all the reasons that we mentioned before. Now what the ACOG organization says is that you must screen for, we recommend that you screen for these disorders and that you find treatment pathways. So they still acknowledge this is difficult, but that obstetricians really need to be key partners in finding treatment pathways. The U.S. Preventive Services Task Force, which many of you may know, recommends that kind of followed suit from the American College of Obstetrics and Gynecology and now recommends that adults be screened, and specifically in 2016 called out the importance of screening for these disorders in pregnant and postpartum women. So you might also be wondering, like, how does this all fit in the context of federal law, and what does the Affordable Care Act or Obamacare do to address maternal mental health? And also, we'll talk a little bit here about mental health parity. How does this all fit into the context of maternal mental health? So first, I wanted to start with the Affordable Care Act. So there was mention and inclusion of these disorders through the ACA through something called the Essential Health Benefits. Again, not limited to maternal mental health disorders, but all mental health disorders. I'm not going to go into the detail about these EHB plans, but you can see here that there can be on insurance plans, there can be no annual lifetime dollar or visit limit for these disorders or any mental health disorders. Also, the ACA requires screening to be covered by insurers. The problem wasn't necessarily that insurers weren't covering screening, though, which we like to point out. It's more that providers aren't screening, period, for a variety of reasons, right? What we already covered earlier. We also like to point out that HMO plans already covered maternity office visits at $0 copay, which would include screening. So there was no patient out-of-pocket cost already. And again, as I mentioned here earlier, well, I didn't mention it, but you may have saw it on the last slide, is that providers also complain that there's no payment necessarily for screening on top of all the other things they have to do. And this is a real opportunity. And the ACA did not require payment for screening and didn't mandate that providers screen, only that insurers cover screening. So I'd like to also talk a little bit about federal mental health parity. In case you're wondering, how does this all fit in the context of mental health parity? And you might remember that mental health parity requires, again, health insurers to cover mental health, all disorders at the same cost share and limit comparable to medical coverage. And now also we want to point out that that if a medical plan covers certain categories, they can't exclude others, and other plans used to cover or exclude mental health coverage. That can no longer happen. I wanted to also share that there's a movement now to address payment parity, which many of you may know about as a problem yourself, right? Are we really being underpaid by insurers? That's something that the mental health parity experts are starting to look at. I want to share that there's a framework for federal legislation that's been called out here. Again, part of the ACA called for additional research on maternal mental health. There were no additional grants that were provided to states, sadly, even though that Melanie Blocker-Stokes Act was included as part of the ACA. And what our experts at the NIMH, the National Institutes of Mental Health, said was there was really no need for additional research. All the research is happening. It's more about implementation. That's where we should be focusing. And then also I'll say that there's a bill that provided grants to states that already passed in 2015, was signed by President Obama. And then there's a pending piece of legislation that our organization is helping to lead that calls for a federal interagency task force. Just the highlights again here is that we all need to know doctors can't do it alone, and that there are some other levers, including working through hospitals and insurers to effectuate change. States are now beginning to advocate for change directly, not just at a federal level. California is one of those states. That's where we're based. There's a white paper that many of you may want to look at. We'll make sure Astrid has a copy of that explains the barriers and the path forward for states. We also, as I mentioned earlier, really want to make sure that we're lifting up the roles that insurers and hospitals and others can play. You can see that there's self-assessments here that hospitals can take around what they can do to effectuate change. Insurers, we have a similar platform for change. We also wanted to share that there has been, as you noted or heard earlier, a treatment shortage of mental health providers, but also a super shortage of maternal mental health providers. Those treatment pathways need to be built up. Here's some resources that are available for those that want to go deeper. And we'd love to work with ADAA on promoting these trainings, and also working with you perhaps to develop additional trainings. We also have downloadable materials. There's a national awareness campaign through the bluedotproject.org that uses the blue dot that happens during Maternal Mental Health Awareness Week. There's also ways that all of you can get involved with community coalitions. So if you're not interested in doing policy work or driving change at a state level, there's community-based organization platforms. We also convene change agents and want to share that our upcoming forum will happen in February in 2020. And then finally, my closing slide here. You heard about the trainings that we offer. There's a complimentary Maternal Mental Health 101 training that those that want to go deeper can share with their colleagues. There's a certificate-based training. Postpartum Support International also offers a new credential, and this training is a pathway to earning your credential and taking that board test. And you can see here, you can follow 2020 Mom through our e-news distribution, and also there's my email for any questions or comments later on. So thank you so much, Astrid and Barbara, and also Dr. Yonkers. I'll turn it back to you.
That was terrific, Joy. Thank you so much. It was very comprehensive, and I think your audience will really appreciate a lot of the materials and links that you provided, as well as the information. We now have time for a few questions. As a reminder, you can still submit questions through the chat box on the little attendee control panel. You may be invited to read your questions aloud. Please just make sure you have a mic. Thank you.
All right, we're going to give participants a little bit of time to think of any questions they may have.
Great. And don't be shy. We might actually offer those who ask a question a waived registration to our Maternal Mental Health Forum in February in Los Angeles, which I know is attractive to many people who live on the East Coast and want to get away.
Yeah.
So don't be
Joy,
shy.
I have a question for you. I'm wondering, what do you tell women who are concerned that because they're depressed, that they may experience some stigma, or it may be perceived as just sort of personal weakness?
It's such a great question. Well, we don't want to be the organization that tells women this. We want obstetricians for their primary care providers, pediatricians. I know we'll hear from a colleague in just a moment about the role of pediatricians in the postpartum period. But we want these disorders to be recognized like any other medical disorder. We often talk about diabetes, right, and new onset of gestational diabetes during pregnancy. That happens less often, right, as these disorders do. The brain is as much of a part of the body as the pancreas, and what we want to see is that obstetricians are the ones that are educating patients routinely, and doing that through screening as early as pregnancy or even pre-pregnancy, right? If a woman is childbearing age. So that's really what we're trying to effectuate, is that it becomes mainstream as part of maternity care. We do educate women, again, that they're not alone, just like Postpartum Support International. 1 in 5 women living in poverty, the rates are as high as 50%. And so for them to know that they're not alone is critically important. So we do like to remind and tell patients that, but they find it quite confusing if their clinician partners aren't telling them first. And so that's really what we're promoting.
Mhm. I'll also tell you that one of the questions that I receive very frequently comes from spouses or significant others, and they'll frequently ask me, and I wonder what your thoughts are about this. What can they do to help their partner or their spouse?
Yeah, that's a great question. And we know what pressure, right, that partners, husband partners are facing when they know something's not right, and what are their resources. They're navigating the complex healthcare system, just like mothers who are not kind of at their breaking point are. What I like to point out again, when our sister nonprofit provides a chat with the experts for fathers, who they themselves, as we hit on earlier, are not immune to these disorders. It's not pregnancy induced per se, but they're at higher risk for these disorders because of the higher stress levels. So depression and anxiety themselves. It's really about finding a champion in the healthcare system, I would say, to help navigate where do I go next? How do I make sure that I have access to a trained provider who has received the certificate-based training in maternal mental health? Again, Postpartum Support International, our sister nonprofit, has a new online directory to find resources. They also have a warm line for providers to call and family members to call to find trained providers. And so it's really the difficult thing is to find a champion to help navigate the system. And Postpartum Support International is doing that well. We're starting to partner with organizations in a broader way around navigating the insurance system and making sure that insurers have adequate provider networks and that wait times aren't too long, et cetera. So unfortunately, fathers are really in the same kind of broken system as mothers and may also be suffering themselves. And so PSI, Postpartum Support International, is a great place to start for fathers as well.
Great.
We have one question from the audience.
Hi, my name is Sherry Steinman. Can you hear me?
Yeah, hi, Sherry.
Oh, cool, hi. So I'm a professor at West Virginia University, and I'm particularly interested in coming up with prevention and intervention strategies for women with postpartum anxiety or postpartum OCD. And I've been looking for funding, and I've mostly been looking at NICHD and NIMH. And I was wondering if you guys, since you're experts in this field, would have any funding agencies you'd recommend I look into.
I love that question. I love what you're thinking about doing around prevention. So like who's at risk for postpartum anxiety, or even, we know onset of anxiety, even OCD can happen during pregnancy as well. So I'd urge you to look at both of those time frames.
Sorry, I was just gonna say, we have a small grant that we're doing just in the state of West Virginia, where we've developed an online prevention program for OCD and anxiety that we're almost ready to start, which is really exciting. But I'm looking to hopefully do like an RCT in the future, so I'm going to need more money.
That's great. Maybe our colleagues on the line will have some ideas. We often get asked those questions, and I'm just not as much of an expert because we don't conduct research ourselves, but others may have ideas. I thank you for the work that you're doing, and I'll also point out that West Virginia is one of the states, because of a screening tool that was developed actually for pediatricians to utilize. Maternal depression is actually on that main screening tool that looks to screen for various things, but it's nice to see movement in West Virginia, and I think it's in part because of that screening tool. So thank you for your work, and please stay connected. I'd love to hear about the outcomes.
Cool.
work that you see. Yeah, so maybe others will share some information about funding. Thank you. Great question, and thanks for your work.
Presentation.
Yeah.
I will also, if I can just quickly add, I didn't touch on during my presentation the other states that are addressing maternal mental health in a big way. If anyone's interested in learning what their state is doing, I'm happy to take questions offline. It really is an issue both from a legislative perspective, but also a regulatory perspective. So departments of public health, for example, are really starting to dig into this. And so I would say you might even have partners in West Virginia in your Department of Public Health that might be interested in something like this. But there's a lot of great work that's happening at a state level. Utah is doing some incredible work. We just featured their program on a webinar yesterday through our Innovation Awards program with 2020 Mom. So I'd say take a look at that recording as well if you're interested in state level work and policy change.
Right. So thank you very much for your question, and the question about research. Really, a lot of this work, I think, is funded by the National Institute of Child Health and Human Development, which covers both maternal as well as child health. And so the funding streams can be a little bit complex. Sometimes they're local state organizations that also provide at least pilot funding. I believe that the March of Dimes has provided funding for some things. They're very active in maternal health. I don't know if they're really in the space so much of mental health, though. I want to take this. There was a question, a very quick question about what is the first thing that we would recommend a clinician do to prepare for someone who may have a depressive disorder in pregnancy or the postpartum time. I don't know, Joy, if you have any particular thoughts on step number one. I'll share with you that my step number one is to make sure you're prepared and that you have resources for people. But
absolutely, I will just add, yeah, I mean, it really is important that all providers, all of you on the line and obstetricians, really start by understanding where are the resources in my community, and if there aren't any, to hopefully be a part of effectuating that change. Hospitals can provide support groups without many resources. For example, understanding the mother to baby, like the resources for prescribing medications that are safe. Mother to Baby is the organization that most of our providers that are prescribers are utilizing and know of. That's critically important. I also wanted to say that ACOG, the American College of Obstetrics and Gynecology, I'm on their expert work group for maternal mental health, and they are releasing a toolkit very shortly with algorithms and how to find these resources. Again, PSI, Postpartum Support International, is the place to go. If you don't know of any resources in your community, you call them or look at their new online directory and start to make outreach to local providers. Yes, thank you, Dr. Yonkers.
great. All right. We're going to move on. Our next speakers are Drs. Margaret Altimus and Dr. Catherine Monk.
Sorry, Dr. Yonkers, we do have a few more questions.
Oh, I apologize.
That's okay.
Okay.
That's okay. We have one question from the audience.
Hi, I'm doing some work in Maryland around trying to get more pediatricians in Baltimore City doing regular screenings. And I'm wondering if you have resources that have been helpful in terms of getting buy-in by the pediatricians. We do have it where pediatricians can bill Medicaid for those screenings.
Mm-hmm. Well, a couple thoughts. I know one of my colleagues are going to present here in a bit on their pediatric model and the work of Healthy Steps, Dr. Hill Briggs, and I know she'll have some thoughts on this. But also, just wanted to share, well, two things. One is that pediatricians, as I mentioned earlier, really long before any other clinical professional or agency, AAP has recognized the importance of these detecting these disorders. What's difficult again for pediatricians is that they can't treat moms, what we have found, though, that does work for pediatricians in terms of engagement is to provide them a simple screening tool. And again, I think Dr. Briggs will have some thoughts on the tool that she recommends, probably the Edinburgh, I'm guessing, but we'll see what she says, and then help them develop their referral resource list. So once they have a positive screen, what do? Our recommendation is that they collaborate with the obstetrician, because the obstetrician really is being seen as the home base now for screening and detection of these disorders, starting in pregnancy or pre-pregnancy and extending through the postpartum period. So again, ACOG is supporting that work. So I would say two things: help them understand what screening tool to use. Well, three things: screening tool, help them develop resource lists, because you're in one community in Maryland. That's probably something that you can help them do, is develop that resource list, referral pathways, and then also help them know how to engage with the obstetrician, who should really be helping to lock down diagnosis in some way, and create a treatment program for the mom. So what is that treatment program, and does it include medication management, other forms of therapy, like electroconvulsive therapy, something like that? Again, pretty extreme, but OBs are really now being looked to understand all of those treatment options. So how to engage with OBs.
And Joy, this is Rahel Briggs. Can you hear me?
We can hear you. Thank you.
Great. I just thought I'd chime in here for the colleague from Baltimore City. I hope you can stay on. I'm speaking after the next pair of presenters, so more like around the 2:30, 2:40 time. And I'll be speaking all about exactly the answer to your question, which is what an extraordinary platform pediatrics is to address PMADs and how to counter some of the resistance and some of the challenges that you see. So happy to give you about a 30-minute answer to that question in about an hour and a half.
That's great.
Wonderful. Thank you.
Sorry, we have one more question, but she's unable to ask it out loud, so I can read it out loud for you. Can you repeat the reference to the article regarding intrusive thoughts? I think you said 50% of women report intrusive thoughts during postpartum period. Did I get that right?
That's right. I will share with you, Astrid, the link to that research. And those who are on Twitter, look for me, Joy Burkhardt. You can find that link immediately. Actually, I'll put it in the chat as well. I'll go ahead and put it in the chat during the next presentation.
Sure.
Great. Well, thank you so much.
Sorry,
I look forward to hearing the other.
We have one last question. Are there strategies that have been shown to be effective at increasing screening rates among providers who feel they are not particularly qualified to address positive screens?
I would just say it takes a village, right? And they're right. If they don't feel qualified, they may not be ready. And so how can you assist practices, obstetric providers and other practices to feel comfortable? And I think that's what all of us will be talking about today. What are those strategies? And I would just say it takes a village. That's why there's multiple speakers here today, psychiatrists, pediatricians, and others, right? We all know that we all have to play a role, and there's not a simple answer there. I'm happy to collaborate with whoever asked that question, though. Again, you can find me at joy@2020mom.org.
Great. I believe that is all the questions that we have today. Dr. Yonkers, you may continue on to the next presenter. And thank you, Joy, so much for your presentation.
Absolutely. Thank you.
Thank you once again, Joy. That was really terrific. And you're a wonderful resource to women and physicians and nurses about this topic. So we have joint presenters, Drs. Margaret Altimus and Catherine Monk. And let me first tell you about Dr. Catherine Monk, who will be speaking to us first. She's a professor of medical psychology in the Department of Obstetrics and Gynecology and Psychiatry, and she's a research assistant 6 at the New York State Psychiatric Institute. Dr. Monk's research brings together perinatal psychiatry as well as developmental psychobiology and neuroscience to focus on some of the earliest influences on children's developmental trajectories. And that is what happens in utero and how to intervene early to help women prevent risk for mental health disorders in their children. Dr. Monk earned her BA at Barnard, and she earned her PhD at the City University of New York. She completed her postdoctoral research training in psychobiological sciences at Columbia University. She has been continuously funded for her research as she's been at Columbia. She's also received funding from the March of Dimes, Johnson & Johnson, the Robin Hood Foundation. Somebody actually asked before about some funding options, and I would listen to this list. So it does appear that March of Dimes does funding in this arena, the Robin Hood Foundation, and the Brain and Behavioral Research Foundation. Dr. Monk has been awarded the key roles on the NIH-wide ECHO project, which is the Environmental Influences on Children's Health Outcomes project, a 7-year nationwide effort to study early factors, including women's prenatal psychiatric illness and trauma histories, on children's health outcomes across 50,000 participants. She's a principal investigator on one ECHO project and an investigator on another that's entitled Intergenerational, and she also has an NIMH grant entitled Intergenerational Transmission of Deficits in Self-Regulatory Control, and a grant that's funded by the National Institute of Child Health and Human Development that is entitled Preventing Postpartum Depression, a Dyadic Approach Adjunctive to Obstetric Care. Dr. Monk is the founding director of the newly launched Women's Mental Health Program, integrated into Columbia's Department of Obstetrics and Gynecology. And I'll turn it over to Dr. Monk.
Great, thank you. Good afternoon. And so I need now to show my screen, and you can all tell me, and is that working? Does anyone see my screen? Because I answered yes. Astrid?
We can see your screen. I can see your screen.
Oh, terrific. Okay, it's the feeling of talking into nothingness, right? You all have done this so brilliantly. I will try to follow suit.
We don't see you, but we see your screen.
Okay. I can try to fix that, but I don't want to waste a lot of our time. My camera seems to be on. Sorry, share my webcam. How's that?
Perfect.
Okay, but now I need to make this smaller so I can actually see my screen. Great. It is such a pleasure to be here, and particularly with colleagues. Each of you mean a lot to me in my work, and I'm just really happy to be here. So what Marty and I decided is that I would speak first for maybe 25 minutes or so, maybe 30. We'll see how we do. And then Marty's going to have her time. And I guess actually in between, before Marty goes, I will, if it's okay with everyone else, take a few questions, depending on what we're doing with time. I think we'll have enough. And then Marty will go, and then I guess we'll see where we are. So I'm also thinking that my topics, it was just so great, Joy, to hear you talk, and I think there's a lot of overlap in our comments in a good way. So I'm actually calling these, it's an acronym that just really came to me learning it in London recently, common mental disorders. So really making the point that anxiety and depression are extremely common, and that can help us as we really try to get rid of stigma. So I'm talking about these common mental disorders in particular, and why women's mental health at obstetrics and gynecology matters. And I can't move my thing forward. This is interesting. Why is that? There we go. Sorry. All right. So we're at women's mental health in relation to obstetrics and gynecology, which is really going to be a theme, and you've already heard it from Joy. It's really in part how to increase access to care. So in many ways, and this is true across a woman's life course, obstetrics and gynecology is really a portal or a main entry point to women's overall health care. And this should be and can be including their mental health care needs. So many of us, many women, maintain a relationship with an obstetrician, especially a gynecologist, over the life course. And it just enhances opportunities to be well known, to leverage that relationship, to have screening embedded there, and good systems for referrals. And those are mechanisms by which we can really increase access to care. And I'm showing you these amazing photographs. I will give a handout. I have not, as my colleagues have done, given a handout, but I will once we're done. These photos will not be there. They are from a wonderful book called 40 Portraits in 40 Years by the photographer Nicholas Nixon. So it's four sisters chronicled over the 4 decades, and it's really a celebration of women across the life course. So I don't have any conflicts of interest to disclose, and these are the funders for my lab and my group. So an overview, really looking at pregnancy and postpartum and making the point that we have more than one patient. Rahel will obviously be touching on that a lot too. Again, this concept of common mental disorders. Wanted to briefly look at the range of risk factors for the CMDs, with the idea that that underscores how we need to have a range of interventions and a range of mental health professionals. And to make this point, I'll be focusing on depression. And then looking quickly at impediments to treatment. We've already heard a lot about that. And then providing information on our new model in obstetrics and gynecology to try to answer what can work now. So as many of you may know, this is a concept, how the first 9 months shape the rest of your life. That is called the developmental origins of adult health and disease, and that some of our future health starts in utero. This is work that I've been doing along with many other labs, many other folks basically across the world. But I want to give you a taste of a recent paper that we just did to illustrate the idea that there's more than one patient. So this is a paper that we recently published, and it's really looking at what kind of, we're calling it stress, but actually we have information on depression and anxiety, and what levels matter, obviously not only for the woman, we know she's being affected, but for the developing fetus. So very briefly, we did a huge, well, we think of it as huge, it's not as huge as some big data is. There were 27 variables that we let an analytic method parse the women into 3 groups, and along some of the different variables you're seeing on the top there. And we came up with a group in purple, so the largest group was healthy. And actually, let me interrupt myself and emphasize that all of these pregnant women were deemed healthy by their obstetricians. They were all getting prenatal care and they were having a healthy pregnancy. So when we asked these more in-depth questions, we got a large group that was very, very healthy. And then as you see in the red, there's a subgroup that was psychologically stressed, and you can see on these mental health variables, they have an uptick. And then you can see we have a group of physically stressed, and those are women who have higher blood pressure, they're eating more calories, particularly high carb calories. But there, again, it's a healthy pregnancy. So we did this data-driven approach and found the women parsed along into these 3 groups. And I want to echo one of Joy's points and say that if you look on the far right there, you're seeing what most differentiated the groups was how they felt about social support in their lives, and particularly with the psychologically stressed, I'll tell you a bit more about them, really lacking in a sense of being part of a community and having people to do errands for them, etc. That's a great entry point for interventions. So what we learned about these 3 different groups, again, the idea that there are at least 2 patients here, is that they differed in terms of birth outcomes. But before I give you that, I want to also, again, echoing Joy, tell you that they were different in terms of their life course. So the 2 stress groups had higher levels of childhood trauma, particularly emotional abuse and physical neglect. And the psychologically stressed group, they rated had perceptions of parenting that were much more negative. Now, going out to birth outcomes very quickly, just want to show you the dramatic increase in the rate of preterm birth in the physically stressed group, and somewhat of an uptick in the psychologically stressed group, at least compared to healthy. Now, as many of you know, the average preterm birth rate is about 8 to 10%. And what you're seeing here is that if we really have a healthy group without these psychological or physical indications of stress, we can really get the preterm birth rate low. And again, that psychological stress is playing a role in that preterm birth rate, and so are these indications of a body that's stressed. The stress is getting under the skin, as we say, and manifested in this higher ambulatory blood pressure and what they're eating. And then in some kind of findings that are rather perhaps surprising, but have actually been shown before in epidemiologic work and some anthropology work, is that we had differences in what's called the secondary sex ratio, so the rate of males to females born. And so typically males, it's about 105 males born to 100 females. But we found that was dramatically shifted in the stress group. So I'll quickly walk you through this. You look at the males, you see that they are disproportionately born in the healthy group. And the psychologically and physically stressed groups have fewer, less than 50%. So I should say it's usually 50-50, and they have less than 50% males. And then for the females, the distribution is different, so that you're having higher rates in the two stress groups. And what we think is going on is that these indications of stress are chronic. They're not just for this pregnancy. So in other pregnancies, maybe the woman didn't even know she was pregnant. She is disproportionately in the stress group losing males. So when the coin is flipped again and she goes on, she's going to be having females, and the females survive. And this is evolutionary biology is shown, and we know that males are born at higher rates of preterm birth. Males are just more vulnerable in utero. So obviously the sex of a baby doesn't matter in the short term. We hope parents are happy with either having a male or female, but these data really show us how much the in utero environment and its potential influences on baby is happening, and the in utero environment being influenced by women's psychological stress as well as physical indications of stress. So just to break down, is the last bit I'll do about this, but often we get asked how much stress matters, and I'm using that as a global term. So here I'm showing you where did these three groups fall in terms of very standard measures of depression and anxiety. And what you can see is in depression, they're around 15, and we know that's a mild to moderate depression. Interestingly, in the anxiety scale, even though we often find, I say this as a clinician and also in some of the research, that depression in pregnancy, certainly postpartum, has an anxiety aspect to it. What we're seeing here is that they weren't reaching criteria for anxiety more than mild. If you go far to the left, you'll see that they were high on a perceived stress scale. And I'm sorry, I'm talking about the psychologically distressed group. And significantly higher than the healthy group. So what we have here, and I just have one more slide that really emphasizes that how much of this stress or distress, the depression, the anxiety, stress, is again not only mattering for the woman, but then affecting the baby as well. Particularly with the Hamilton depression, we can see women in a mild to moderate depression. We have evidence, as I just showed you, that that's affecting the birth outcome. So it's mattering for them as well as their future babies. So we really have two generations. There's more than one patient when we are wanting to help a pregnant woman with anxiety and depression. So I'm really going to echo some of what Joy said, but just to really keep in mind, adult women, 20% in the United States will experience a major depressive disorder at some point in their lives, and that's twice the rate of men. And so then when we go into the major and minor depressions during pregnancy, where the low is 8%, 11%, and we get somewhat higher, up to 13% in this study when we're looking postpartum, and again, just even up to the 20% in this other study in pregnancy and postpartum. And the rates may vary, as Joy already indicated. Poverty is certainly an additional risk factor for this having depression. And just to, again, really wanting to go in the direction of common mental disorders. Women are more likely to be affected by generalized anxiety disorder, panic disorder, PTSD. And we look at the rates of anxiety disorders. The 12-month prevalence of any anxiety disorder for women is nearly 15%. And then you get 12% in pregnant and postpartum. And I'm using that term. We've already heard a good discussion of this from Joy, and really already had this idea. PMADs are the #1 complication of pregnancy and childbirth. 1 in 7 women will experience them. This is from a great study from Mathematica, which I encourage you to look at. I want to just quickly make the comparison to bipolar disorder, which is really 1% of women in their lifetimes. And when you see these rates here, 2.3, 2.8%, when we're looking at women in the pregnant and postpartum period in a 12-month prevalence rating. And then schizophrenia, 1.7% lifetime prevalence for women. And then, that gets us thinking about this very serious condition of psychosis in pregnancy. But even in a review study, even the highest rate was 5 in 1,000. So these are very serious, but much less common disorders. So depression and anxiety disorders are common mental disorders. They're CMDs versus bipolar and schizophrenia. And they're the ones the obstetricians and gynecologists are most likely to see. So partnering with these providers, we really can improve identification and access to care. So I want to go now quickly through some risk factors. This is just such a really a light little taste, but to again making the point of how much we need a diverse workforce in order to address these issues. And the papers I'm citing, interestingly, are from someone named Ken Kendler, who is a leading geneticist and biological psychiatrist. So here he's looking at the sources of parent-offspring resemblance, the familial inheritance of major depressive disorder. And this paper comes down on the side that parent-offspring, both having a major depression, it rises from genetic factors and rearing, so the childhood environment, in approximately equal extent. This is another paper he did looking at stressors in the lives of men and women that seem to contribute to depression. And for women, it seems to be more that these triggers are around deficiencies in caring relationships and interpersonal loss. Whereas for men, it's the failure to achieve expected goals and having lower self-worth. We all know about ACEs. Again, Joy brought that up. Very important to keep in mind these adverse childhood experiences. You saw it in the data I just presented. These have lifelong impact. And here, just looking at women versus men, and based on their ACE score, sexual abuse, physical abuse in their background, the number of ACEs, as the ACEs go up on the x-axis, the percent of those people who have a lifetime history of depression. And you're seeing women higher than men. We know that, or at least it's acknowledged and identified in women. But you're really seeing, even with 3 ACEs, 40–45% of women have a lifetime history of depression. It's a huge risk factor. And one reason, again, as Joy said, we should, aspirationally also be screening for that to prevent these mental health conditions, in pregnant postpartum women. And just, quickly, when we, in a couple of studies have shown how common these ACEs are. Nearly 50% of US children have at least one. Another study showing kids between 12 and 17, 30% have had 2 or more ACEs. So these are common, these are not rare. This is a terrific paper from Neil Epperson, who also works, really a leader in women's mental health, looking at having a background of ACEs, and then how for some women, in combination with these periods in life of significant hormonal shift, that's when you, that can be a pathway to having a depression or anxiety disorder. So again, when are hormonal shifts happening? Puberty, pregnancy, postpartum, menopause, these are times when there's going to be contact with the obstetrician or the gynecologist. Finally, a study really emphasizing the heterogeneity of depression and thus the paths to get there. Different genes of risk in those seem to be associated with depression, and it differs for those who have ACEs in their background and those don't. So for those with ACEs in their background, it's certain genes in combination with the environment, and those seem to be different loci than the path for those without ACEs in their background. And lastly, one of my favorite studies, Unequal Depression for Equal Work, how the wage gap explains gender disparities and mood disorder. And really, the title says it all. But what you're seeing here is the evidence and the knowledge of not making comparable money for the same work is indeed a risk factor, and for women to have depression may help explain some of the gender disparity and mood disorders. So with this background, I'm again going to Ken Kendler because he wants to remind us of the different pathways, and here I am focusing on depression, to get to depression, same story for anxiety though, and what that means and how we conceptualize the etiology of these disorders, and that has implications for treatment. So for those of you who remember your Descartes, we are to shed the chains of Descartes and not have mind-body dualism, but instead think of the mental and biological as different ways of viewing and or different levels of analysis of the mind-brain system. So they're the same system. So he wants to remind us that psychiatry is grounded in the mental first-person experiences, and very important with the arrows here. We can have mind-to-brain causality and brain to mind, and mind to brain. So both directions in terms of getting someone to have, say, a depression. So this means that the mind experience. Oh, am I still on? I just heard a muted, unmuted. Okay.
Oh, yes.
Okay, I'll keep going unless I hear something else.
Sorry, Dr. Monk. I believe something might be hitting your microphone, so it's kind of causing.
Oh, I'm sorry. I'm glad you told me. Is this any better?
Yes, that's perfect.
Okay, I beg your pardon. Yeah, please do tell me, because of course we're here in the ether and we have no idea how we're coming through.
No problem. Thank you.
All right, so if we have these the direction of brain to mind in terms of contributing to a depression, and we also have mind to brain, that influences how we think about fixing mental disorders. We can go at it brain to mind through psychopharmacology and mind to brain through psychotherapy and other behavioral interventions. And he really asks us to keep in mind this plurality in our explanations, and we do not want to fall on biological reductionism. And what he means by that is that to assert that the origin of depression is largely biological conflates biological description with the concept of cause. Biological explanations often provide the underlying how of behavior and mental functioning, but they do not necessarily answer the why or what caused this to happen question. So I tried to give you some of those risk factors. Those are more of what caused this to happen. Some of them get at the description of biology of what may be going on, but we really need to be thinking about mind and brain together, functioning together and being different levels of analysis, and then having this bidirectional influence on each other. So this range of risk factors, we need to then have a range of interventions because we can target the risks or the pathways to the depression from different approaches, and we need a range of mental health professionals to meet this need and this conceptualization of depression as well as anxiety. I want to emphasize this with a great paper from Charlie Nemiroff from many years ago, and I'm just going to jump to the data slide because it really explains it. This is a study of women all of whom have a chronic depression. In the red, it's without early life trauma. We call those ACEs now. And in the green, it's with early life trauma. So if you just focus on the red, what you're seeing on the y-axis is the remission from depression. So in the red, the antidepressants are helping a lot of women remit. And then when we have this antidepressant and psychotherapy, it's a much greater level of remission. More women are remitting. And we think of this as the evidence-based treatment. This is the model of treatment that is really deemed to be most effective for treating common mental disorders. Although interestingly, when you look to the women with the trauma in the background, they're not getting as much remission from antidepressant. And with the psychotherapy, they're getting considerably more, and they don't get a big uptick in remission rates when they go to the combo treatment. So again, illustrating the heterogeneity of how folks get to have a depression, and that has implications for the kind of treatments that are needed. So there are, and I'm not going to go into a lot of details, there are so many effective psychotherapies to treat depression and anxiety. I'm focusing on these because Marty is going to be taking up some, what is known about medications and how effective they can be, and what I believe she'll get into what to use when. But we've got CBT approaches that now include behavioral activation. We have a lot of mindfulness-based CBTs. Both of the top two have been extensively studied in pregnancy and postpartum. Problem-solving therapy is used a lot, I know, in some of our community clinics. IPT has been, interpersonal psychotherapy has been shown to be very effective for pregnant and postpartum women, also in a group setting. Exposure-based CBTs, cognitive behavioral therapies are really the go-to, particularly for anxiety disorders. So we've heard, and I really made the point, that these are common, these anxiety and depression are very common, and yet, as Joy already described, they're really undertreated. So half of perinatal women with a diagnosis of depression do not get the treatment they need. And what then are the barriers to treatment? And here I'm borrowing a slide with permission from Nancy Byatt and Tiffany Moore-Simas, who of course are the great creators of MCPAP for Moms in Massachusetts. So barriers to treatment, again, you've heard a bunch about this from Joy: lack of detection, fear and stigma, limited access. I'm highlighting ones I'm going to be addressing, but I think there's some key ones: lack of integrated care, and having isolated providers. And really, the logistics, the location is really an issue, because when you are making a referral with the best of intentions, and this can be, as many the questioners were raising, it can be such a burden to these practices, it can be also a cold handoff. The provider, trying to do their best, ends up giving a name and a number in a nearby mental health facility, and that often is not followed up on. So location really matters. I also want to say that insurance, again, Joy touched on a lot of this. This is a huge issue. So this is supposed to be raise your hands if insurance is a problem in terms of getting access to mental health providers who take insurance for the perinatal postpartum patients. And this is really illustrated well in a paper that came out from the Milliman research report. And really just the take-home message is in pink, is that compared to other primary care compared to primary care services, getting mental health or behavioral health care, it's almost 5 times more likely that someone will go out of network for that care at a great cost and inconvenience to them, because they just can't find providers in their network. So what can work now? How can we solve some of these problems? And I want to describe, Kimberly already said, that we have a new initiative in obstetrics and gynecology at Columbia where we're trying to solve some of these problems. I welcome thoughts and collaboration and other ideas on how to build on what we're doing. So this is NASA's picture of a sun rising. So this is supposed to be a new day. And this is on the website at the Obstetrics and Gynecology. You can read if you're interested in a bit more about what we're doing, but I'm going to describe some. So women's mental health at OB-GYN. So the Obstetrics and Gynecology department has hired, I have now switched, so it's my primary affiliation. They've hired psychologists, social workers, psychiatric NPs for the psychopharm as well as psychotherapy, hired in the department. So we're seeing patients in the same office space as our obstetrician, gynecologist, maternal fetal medicine, et cetera, colleagues, literally down the hall. We have a bridge to psychiatry when it's needed. So we're really addressing the providers feeling isolated and not knowing where to go. We're addressing the problem of a lack of integrated care. We're 10 feet away from them. And they are now much more willing to detect problems, as already this was raised, because they know what to do when they detect one. We're there to offer the provision of mental health. And I should say that because Columbia is only now going on to EPIC, and we're doing that very soon, in the next couple of months, we will start universal screening. But I think you'll see we're already getting a lot of referrals even without universal depression screening. We're also addressing stigma, and I think, again, Joy, I keep on referring to your talk, but we are, this idea that mental and physical health, we're really putting them on a level playing field. They're just part of overall health. You go to this door to have your prenatal visit, and you just go 10 feet away and you're meeting with your mental health provider. And we really are improving the logistics for patients. Finally, we're using telemedicine through American Well, and this is ideal particularly for the postpartum period. We have a absolutely line in the sand rule that we have to have a face-to-face with each patient before we start to engage in telemedicine, because we really want to have a good sense of where they are. But for most cases, when the inconvenience of coming in, this has been terrific, although I also will say women are coming in and bringing their babies to the session, and we welcome that, and that can be really effective. So we are accepting most insurances. And so, again, this has been discussed. It's a complicated issue. To a certain extent, the driver of the mental health professionals not having enough of them who are taking insurance is, as was described, the low reimbursement and then the high administrative costs for them to take insurance, and it just doesn't work as a financial model. We're leveraging an existing administrative infrastructure in obstetrics and gynecology, which is allowing us to enabling us to take insurance. We're also using office space of theirs outside of typical hours, so that's also, if you will, a cost saver. It's economy of scale. We see patients as therapists and psychiatric nurse practitioners at 8 at night, and typically the other providers are absolutely not there at those hours. It's also great to do groups after hours that way. This is enabling us to take insurance and therefore really addressing the limited access problem. I don't expect you to read this. I really just wanted to point out we have a clinical coordinator who is herself a licensed mental health professional. She's a social worker. And then we have a care coordinator who can help with billing questions. So last bit here, I just want to give you a sense of how we're doing. I think I have just a few minutes left. So since August, as you can see, we've had over 300 referrals. We get about 8 a week, and we're able to get back to each patient as well as the provider to tell them, what's going to go on. But we do that within a day. And we've had to do a warm handoff, so it's always a warm handoff. It's a provider we know they take their insurance, we know they have an opening. We've had to refer 90 out. We anticipate that number to go down. Of those referred out, there are 2 insurances where it's been tricky, but we're getting up to speed with them. Before we had our psychiatric nurse practitioner, we were having to refer out to psychiatry. We've run out, sometimes we get over capacity, but we're hiring up. Sometimes location, people want to be seen closer to home, say in New Jersey, and we're in New York City, so we give them a warm handoff to someone in Jersey. This gives you a sense, and again, this has come up in the prior talk, just in the middle line there, you can see the most need we're seeing is for behavioral interventions. Some are for psychopharm, and we've had 2 situations of imminent, risk and concern, and we are able to be on that within hours, and even going over to where the patient may be if we're not physically where she is that day, and doing an eval, bringing her to the emergency room, whatever is needed. So I'm showing this picture again as I wind up, and to say that attention to women's mental health and OB-GYN will improve women's health across the life course, and the perinatal period is really a prime time for this collaboration. And this is my lab website, Perinatal Pathways. Welcome to visit us. And I will again make slides, a handout, of these slides for anyone who's interested in women eating together, which is always happy. So that's where I'll end. Thank you.
Thank you, Dr. Monk. Dr. Yonkers, you are still muted. There you go.
Oh, sorry. I wanted to thank you very much, Dr. Monk. That was wonderful, and it's really exciting to hear what you're doing at Columbia. I think we're going to wait to hear from Dr. Altimus, and then we'll entertain questions for both of you, if that's okay. So our next speaker is Dr. Margaret Altimus, who is a psychiatrist with expertise in the impact of hormonal changes on women's mental health. She did her psychiatry residency at Yale University and then trained at the National Institute of Mental Health. She's a private practice in the Upper East Side of Manhattan and is also an associate professor at the Yale School of Medicine, where she teaches and does research in women's mental health. She has extensive clinical and research experience in premenstrual mood disorders, pregnancy, and postpartum conditions, as well as menopause. So, Dr. Altimus, are you with us?
I am. I just need a reminder how to share my screen.
Yes. No problem. I will be sending you a request shortly.
Oh, I got it. Okay, great. Okay. Is that working? Can you see it?
We can see your screen. Now, there should also be a little webcam button that you can click on that will show you.
Okay.
I'm about to unshow me. Okay.
Right. Okay, go sitting the right way. Okay, that's good. Okay, great. And does the are you seeing the regular slideshow?
No, we are seeing the presenter view.
Okay, so let me just switch that for you. Let's see. Does that look better?
Yes.
Okay, great. Okay, so thanks a lot. The two talks have been a really good lead into what I'm saying and have covered a lot of that I'm going to be referring to. And so what I'm going to, Catherine just talked a lot about what happens during pregnancy and how it can impact the fetus's development. And so I'm going to try to talk a little bit more about what you should do when you when we have women who need treatment. Let's see. I also don't have any financial interests or other relationships with industry relative to the topics being discussed. The main things I want to cover is just, there's certainly no time in this half an hour to cover all kinds of psychiatric medications, but what I do want to do is give you an overview, kind of a guidance for how to discuss medication with patients, and also some of the new devices that are available, and how to help women who are either pregnant or planning their pregnancy. I also want to help people understand the limitations to what we have in this field, which is mainly observational study designs and case reports. And I hope that we can get some perspective on understanding what magnitude of risk is of psychiatric medications versus relative risks. And then at the end, I'm going to run through the benzodiazepine literature as sort of an example of these principles. So we've been talking a lot about in the last two talks about women who develop psychiatric disorders or stress and anxiety disorders during pregnancy or postpartum. But a lot of these illnesses are chronic, particularly the anxiety disorders. People that have OCD or panic tend to have them, for quite a bit of their adult life. And what it turns out that American women really take a lot of psychotropic medications. About 25% of women in the US will be taking psychotropic medications compared to 15% of men. And some of the reasons for this are that women are more likely to seek treatment. They're also more accepting of treatment, but there are also some gender differences in the just the prevalence of these anxiety and depression disorders. Now, on top of this, if you've got this many women taking psychiatric medications, you've got to add on to that half the pregnancies in the US are unplanned. So that means besides the condition we've been talking about of people developing psychiatric disorders during pregnancy or postpartum, we're also faced with a lot of women who have these disorders as they're heading in to pregnancy and the postpartum period. The good news is that if someone's going to plan their pregnancy, if they really want to make their pregnancy go as well as possible, this is a time when a lot of women are more motivated to consider psychotherapy treatment and also to consider trials of reductions in their psychiatric medications. So we have some women who've been sort of limping along with depression and anxiety symptoms and haven't really been motivated enough to get any kind of treatment. And as they're preparing for pregnancy and possibly getting screened in their OB, in their primary care office, and realize that they do have significant symptoms, they would be motivated to have a healthy pregnancy to, address the symptoms, whether through psychotherapy or with medication. Then the other group of people, there are a lot of people who take psychiatric medication. They were started on it at some point years ago and it helped, so they just stayed on it for years and years, and they haven't really, pregnancy is a time where they might be motivated to try to figure out whether they really need this medication or not, or there are alternatives that could keep them feeling well without using medication. What we don't want to see is women, and unfortunately it happens a lot, where women will abruptly stop their psychiatric medications because that stopping a medication suddenly makes it much more likely that they're going to have a relapse. And we also don't want to be put in the position of trying medications that we don't know whether they're going to work or not during pregnancy. So if there aren't that many medications that are absolutely contraindicated during pregnancy, but if a woman is taking something like that, you want to be able to try the alternatives before before she gets pregnant. So there's a exploding literature about psychiatric medications and birth outcome and birth defects and development of children who are exposed to medications in utero. And really what you're seeing with almost all of these papers are associations. So they'll look at people who took psychotropic medications during pregnancy and see how their pregnancies went and see how their children developed and compare them to people who didn't take medication or compare them to people who had diagnoses of psychiatric illness and didn't take medication. So in these study designs, we really don't know what caused the adverse outcomes. And in some, so here's some possible pathways to consider. In some, it's possible that the psychotropic medications do actually directly cause a negative birth outcome. And say the best example of that, which we can believe, is that, say, valproic acid, which is a anti-seizure medication that's used for mood disorders in women. That is known to cause, very commonly cause neurodevelopmental defects, including spinal bifida and reduction in IQ or cognitive function. But then there aren't that many medications where we can really say they have a direct effect to cause adverse birth outcomes. Instead, what we see a lot is that just their associations. So a second pathway that could be happening when you look at impact of psychiatric medications is that there's characteristics associated with the use of psychotropic medication that affect birth outcome. So for example, if you look at pregnant women who use psychiatric medication versus those that don't, the ones that are using psychiatric medications tend to have more severe illness. And even when they're taking medication, they're often not symptom-free. So you don't really know when you see an example, when you see an association between medication use and a bad birth outcome. It could be the more severe psychiatric illness, and that's very difficult to control for in studies. We usually don't know how severe someone's illness is. Shorter sleep duration is something that's that you see a lot in people that use psychiatric medications, and that in itself is known to impact birth outcome. Medical comorbidities are more common in women who use psychiatric medication, and the medical comorbidities can impact birth outcome. People who use psychiatric medications have more smoking, more substance abuse, they're more likely to be overweight, and all of those things can increase the risk of complications during pregnancy. And then a third way that medications might be associated with negative birth outcome is you may have genetic factors that, say, genetic factors that make the woman tend to be more, develop more inflammatory illnesses or autoimmune illnesses. So that this a tendency to develop inflammation more readily could make someone more likely to develop gestational diabetes, more at risk for prematurity, and also make them more likely to get depressed or anxious. So that you can have a genetic factor that could cause both the pregnancy complications and cause the psychiatric and contribute to developing the psychiatric illness. Similarly, there are some medical illnesses like thyroid disorders, which increase the risk of getting depressed and also increase the risk of birth complications. Women who are hypothyroid are more likely to have gestational diabetes and premature delivery. And so the reason I'm going through these is that even though as we talk about the risks of psychiatric medication, we have to keep in the back of our minds that it may not always be the psychiatric medication itself that's causing the birth complication that we're talking about. I'll just say one, just going back a slide, one of the best examples of the more severe psychiatric illness is you've probably all seen in the news. There have been a number of papers suggesting that that babies that are exposed to SSRIs in utero are more likely to develop autism. And there've been a number of studies showing that, but then there have been a few studies that have controlled for a lot more factors, and studies that controlled for how many episodes of psychiatric illness, like how many psychiatric hospitalizations a mother might have had in her life, or how many episodes of taking medication she had in her life, that when the control for severity of psychiatric illness is put into the model, then the SSRIs are not associated with autism anymore. It's really the amount of the severity of the mother's psychiatric illness overall that's related to the risk of autism. I have this slide here just to show you that I've listed four different birth complications on the left that sort of are increasing in levels of how common they are. So pulmonary hypertension is a risk. It's an illness that babies are born with, where their lung vessels don't open up. And it's a very rare illness. It happens about 1 in 1,000 births. And although studies are conflicting on, there's sort of an estimate that taking SSRIs may increase the risk of this by 50% or 100%. So this sounds like a very serious illness. And when a pregnant woman and her clinician are sort of trying to think of how to conceptualize this risk, it's such a rare illness that even if the risk of it is doubled by taking SSRIs or is increased by 50% by taking SSRIs, it's still very unlikely that someone's baby is going to get pulmonary hypertension. One thing I find very helpful when I'm talking to mothers who are feeling bad because they can't get along without their psychiatric medication, or they've gotten to the point that they're considering taking psychiatric medications, is to point out all the other risk factors that they don't have. So smoking increases the risk of pulmonary hypertension. Taking aspirin massively increases the risk of getting pulmonary hypertension, and obesity also increases the risk. So I also find it helpful talking to women to point out to them the things they do have control over and the ways they can be healthy to reduce the risks of these same complications that may be raised by taking psychiatric medications. Again, birth defects are much more common than pulmonary hypertension. That happens in 30 out of 1,000 women, or 3% of women in the population will have birth defects. It looks like after many, many studies that SSRIs really don't increase the risk of birth defects. On the other hand, smoking increases the risk of birth defects. Obesity increases the risk of birth defects. So again, I think it's helpful to point out to women the healthy things that they are doing and behavior changes they can make that can reduce the risk of pregnancy complications. Preeclampsia, or which is a severe form of hypertension during pregnancy, but also hypertension during pregnancy, that has a similar base rate, about 4%, or about 40 women per 1,000 would develop preeclampsia during pregnancy. Now, interestingly, there's been some new studies, one of them by our moderator, Dr. Yonkers, showing a really increased risk of developing hypertension during pregnancy or preeclampsia if women take SSRIs during pregnancy. This has not been publicized very much. I don't think people have been thinking about it, but new research has been pointing this out. So and that's a similar, you have a similar increase in risk for preeclampsia for women that have obesity. So here you have a relatively common pregnancy complication, which could be increased a lot by taking SSRIs, or increased threefold. So that's something that I think a person would want to think about the most. Another risk of prematurity is even more common, where, again, depending on the population, the age of the woman, socioeconomic status, risk of prematurity is variable, but say on average, 110 per 1,000, or about 11%. SSRIs do increase the risk of prematurity by about 50%. But another way of looking at this is the length of pregnancy would only be shortened on average by about 2 days in women who take SSRIs. That's also increased by smoking, and also increased depending on the level of obesity, but prematurity is more common in more obese women. So when you look at these studies, you really need very large studies to detect rare events. So things like pulmonary hypertension. So usually people use medical record databases. There are a lot of good studies from Scandinavian database records and some from Medicaid database records. The problem is when you get these really big databases that were collected for other reasons, they often don't have a lot of the covariate information that you need, say, detailed psychiatric histories of the women, or sometimes they don't have their BMI, or they don't do a good job collecting all the different medications that they're taking. So just to give you a perspective, if you have 800 exposed subjects, if the base rate of the problem you're looking at, let's say birth defects, for a base rate of 3%, like there's just 3% risk of birth defects in the general population, you can, even if you have 800 women exposed to SSRIs, you can only see birth defects that are 3 times more common or larger. So the more subjects you have in the study, the smaller increase in risk you can find, but it can be difficult to find all these exposed subjects at the level of detail you would want to control for all these other factors. The factors are very difficult to tease apart, and people use very sophisticated statistical models to do this, but often, unfortunately, some of the findings that get the most press and get the most publicity are not as well controlled and are not accounting for all these other factors. And again, I'd go back to the autism SSRI link as one of those examples. Just to talk for a minute about lactation, in general, the exposure that the fetus has, or the offspring has during lactation to the mother's psychiatric medications is an order of magnitude less. So when the baby's in utero, they're sharing blood supply with the mother, so the levels in the fetus are often quite similar to levels in the mother. But during lactation, the drug level in the blood is fairly similar to the levels in the breast milk. But then when the baby is consuming the breast milk, the levels are much lower than the amount that would be in a pill, and then that goes through the infant's liver before it ever gets to the regular bloodstream. So usually the exposure to the infant is low, or at least 10 times less than what the mother is receiving. That's just sort of a general rule, but lithium and lamotrigine are exceptions. There, the infant often gets a third of the exposure that the mother is getting. Unfortunately, the data we have about the risks of babies being exposed to psychiatric medication during lactation is very, very limited. We have much less data to work with than we do in pregnancy exposure data, mainly because people don't keep good records of how much mothers are breastfeeding. In the big medical records databases, there's usually not any information about how much people are breastfeeding. So almost all the data we have is in case series or case reports. And the problem with that is if 3 people have reported that a baby who was breastfeeding and exposed to bupropion had a seizure, we don't really know what is the risk. Like, we don't know the denominator of that. Is that 3 out of 100, 3 out of 10,000? We really don't know because we don't know how many seizures were reported and how many babies were exposed to bupropion through breast milk. So we have to work with what we have, but it's very, very limited information. What I find the most reassuring when trying to talk with people about the risks of breastfeeding when they're taking psychiatric medication is if there is some case report data about levels of the drug in the baby's bloodstream. So, and often there will be information. I have a slide at the end about resources for looking things up, and a great resource is LACMed, and they keep very up to date. It's a database run by the National Library of Medicine, and it's kept up to date. And there you can actually see all the case reports that have been published and see if it's available what the levels of these different drugs are in the infant bloodstream. And often it's quite low. The other thing to think about when you're talking to someone about whether she wants to take medication when she's breastfeeding is that women are really get pressured very much to breastfeed these days, and sometimes the health benefits for the baby of breastfeeding are somewhat overstated. I think the problem is when they do studies comparing babies that are breastfed compared to babies that are bottle fed, people have found all kinds of differences in rates of infection and IQ and ear infections. But those studies are not very well controlled because there are big differences in the populations of women that choose to breastfeed and populations that choose to bottle feed. And but there have been some studies that have creatively controlled for those differences. One way they do that is pay women who were planning to bottle feed, they'll pay them to breastfeed. So this is so you can have a population of women who were planning to bottle feed, pay some of them to breastfeed, and then look at the differences. And in that study design, they really don't see health differences in the offspring. Another design that people have used where they haven't found differences or else very, very little difference between babies who are breastfed and bottle fed is if they take one family and compare the health of one child who was breastfed and one child who was bottle fed within the same family, because there they've controlled for socioeconomic status, cultural factors, and the general psychosocial environment for the children. So again, I think it can be, some women are very disappointed at the idea of not breastfeeding, but can be reassured if you explain some of these findings to them. Another option to reduce exposure to psychiatric medications during breastfeeding is to partially formula feed. A lot of times lactation consultants will say, oh, they really discourage women from doing supplemental feedings with formula because they say that the babies will not be able to develop breastfeeding, good breastfeeding practices, but that's really not so much the case. Lots of people are very successful at supplementing with formula. So say you're sitting down with a woman and you're trying to weigh the risks and the benefits. Should this person try to go off medication, or should they start medication if they've become ill during pregnancy? So I think the first thing to think about with the person is, will they be able to tolerate withdrawal symptoms? Say they've been on chronic benzodiazepines. Will they be able to tolerate lowering their medication, or will they be able to tolerate, say if they've got chronic depression, will they be able to tolerate their symptoms if they go off medication? And if they've never tried to go off medication, then that's why it's really great to plan before pregnancy and give them a chance to try to do it before they actually become pregnant. A second big factor is whether the patient is willing to try an alternative way of managing their depression or anxiety. So are they willing to put the time into doing psychotherapy or doing some alternative practices like yoga or meditation or light therapy? And another question is, have they tried these alternatives and failed them in the past? If that's the case, that would sort of argue towards that they'd be less likely to get by without medication. Another thing about thinking about going off psychiatric medication is some women, because they feel more dysphoric or more dysregulated, they may be more at risk of substance abuse in response to their underlying illness or their withdrawal symptoms. And another thing that I think is a good thing to look at is how severe would their insomnia be. Say people who have been taking medications for sleep and they're thinking about trying to stop that for pregnancy. I think it's really good. It's not good to try to go through pregnancy with insomnia. There have been studies showing that shorter sleep duration, so sleeping 5 hours or 7 hours during pregnancy, has been linked to increased rates of premature birth, shortened gestation, gestational diabetes, and also to development of depression later in pregnancy. So we really don't think that people should just go off their medication and sort of grit their teeth and try to get through pregnancy, because having shorter sleep, or as Catherine discussed in the last talk, experiencing stress and anxiety during pregnancy can lead to adverse birth outcomes. There's different articles out there and even some books talking about how to taper medication. I think here's some general principles of how to help people taper off their medications or try to taper off medications in preparation for pregnancy. It should be a shared decision-making approach, so let the patient feel like they're in control of how this is going to be done, and help them choose the ways to manage their symptoms as they go down on the medication. Provide reassurance and anticipate that they may get rebound insomnia, anxiety, depression, or mood lability. And again, encourage them to find alternative ways to manage this. It's really hard to make guidelines for how to do this because everyone is different and they're taking different medications. So you really need to individualize the plan for different women. You want to consider referring them to CBT or some kind of other psychological therapy to help manage symptoms. And I think it's really good to consider starting the alternative treatment before they begin the taper. So, or at least have, if you say a woman's feeling fine on their SSRI and they're going to start to taper, I think it's good to have them have someone that they've met with who's going to be their therapist or their psychological support, that they meet ahead of time, so that person can take over if they start experiencing symptoms with the taper. It's good to have goals, like what symptoms are we looking for as the person tapers, and then plan for frequent follow-up visits, and just realize that people that have been using medications chronically, especially benzodiazepines, might need a slow taper over many months. So again, with this point in mind that people need to taper slowly over months, you really are in a bit of a bind when people become pregnant unexpectedly. So again, we really don't recommend, except in a case of a few medications like valproic acid, to stop these medications suddenly, because the consequences of if you stop them suddenly, people could really not tolerate that well and have a bad relapse. So as Catherine mentions, there's so many psychotherapy alternatives as people are trying, want to stop taking medication or want to avoid taking medication during pregnancy. I especially want to emphasize the second one here, cognitive therapy for insomnia, that it can be very, very effective and really help people who have been taking sleeping medication chronically. I mean, it can be really surprising how well that can work for people. It's a combination of a psychoeducation and a real understanding about sleep, and then there are a few interventions that are individualized for the people that are doing the therapy, and it works very well, and it's not a lot of sessions, usually 5 or 6 sessions. Again, supportive therapy, psychodynamic therapy, interpersonal therapy has been studied a lot during pregnancy, behavioral activation, some of these alternative interventions. As Catherine mentioned, access is really difficult. So I think in trying to support women who are pregnant and postpartum, we really need to use telehealth, think about web-based treatments that they can do through the computer, and also have treatments, as Catherine was talking about, integrated within primary care so that to improve access. I'd say I work at a VA here, and VA is worked hard to have mental health treatment available in primary care, to the point that the mental health people that work in primary care have every half hour free, so no patient would ever have to wait more than 20 minutes, theoretically, to have an appointment with a mental health provider. Although we really don't see many pregnant women here, so it's not really solving the maternal mental health difficulties, but that's a model that I think can work to really just maximally increase access, to have a mental health provider that's right there, that's free when a screening is positive.
Sorry to interrupt, Dr. Altemus. I believe might be something wrong with your audio. Might be your mic.
Oh, really?
Yes, I think you might be speaking a little too closely to your mic.
Is it like feedback?
Oh, nope, there you go. Can you try testing it? Yes, there you go.
Okay, sorry. Okay. There's some other biological treatments that are very promising, but at this point we have only one or two randomized trials with each of these. One is light therapy, which is very effective for depression in non-pregnant people, and in fact the effect size of light therapy is very similar to the effect size of antidepressant medication. It's underutilized and sort of underpublicized, but there has been one randomized trial in pregnancy, and it was effective for depression during pregnancy. So at this point, there's too few studies to estimate any risk of doing light therapy in pregnancy. It seems like it would be low risk, but we don't know for sure. Another one is transcranial magnetic stimulation. This treatment's a little more difficult because people have to come in to the office 5 times a week, but there has been one randomized trial in pregnancy which was effective for depression. Again, that's too few studies at this point to estimate risks, but these are studies where women would be able to be treated and there wouldn't be any medication exposure. So those are sort of on the horizon as possible. As I mentioned at the beginning, I wanted to talk about benzodiazepine use as kind of an example of how to think about medication risk during pregnancy. So in a cross-sectional analysis of U.S. survey data, the prevalence of benzodiazepine use in women is over 15%. So at any one time, 15% of women are taking benzodiazepines. So when you think about the high rates of unintended pregnancy, a lot of women are heading into pregnancy using benzodiazepines. Another study looked at women using private insurance. This was in the Boston area, and they found that 4% of pregnant women had filled benzodiazepine prescriptions during pregnancy. And there's another concern is that more potent illicit benzodiazepine compounds are now available through the internet. And in fact, the reproductive risk of benzodiazepines seems to be higher than that for SSRIs. There's multiple reports of associations of benzodiazepine use during pregnancy with premature birth. There's also multiple studies showing that there's neonatal respiratory impairment in offspring, increased risk of that in offspring that are exposed to benzodiazepines during pregnancy. We don't think there's risk of impaired fertility or birth defects, but there are risks of these pregnancy complications or as the fetus developed. There's one study found small effects on motor skills and communication when children exposed were 5 years old, but this was only for mothers taking benzodiazepines for depression and anxiety, and only if they took them during the 3rd trimester. They didn't find that in mothers who took benzodiazepines for pain or insomnia. So that's somewhat reassuring in terms of effects on offspring. And then we're left with these case reports of sort of a floppy baby syndrome and withdrawal seizures that hasn't been found in these sort of larger, more carefully done observational studies. In terms of the teratogenic risk of benzodiazepines, this is some of the early studies used a case control design, and they showed increased risks of oral clefts and also major malformations in babies exposed to benzodiazepines in utero. But some larger studies and studies using medical records and prospective cohort designs now have shown no increased risk of birth defects, although the risk might be increased in combination with an SSRI. So if you met with a woman who was taking them, usually the first thing on people's mind is, oh, is this going to cause birth defects? You might be able to say no for benzodiazepines, but there could be increased risk of these respiratory problems after the baby is born or premature birth. So again, thinking back where I talked before about the pathways to these adverse birth outcomes, women with more severe anxiety are more likely to use benzodiazepines during, and people with more severe insomnia are more likely to be using benzodiazepines because it's usually not a first-line treatment when people are giving psychiatric medication. So remember, we talked before that people with more severe anxiety and more distress are more prone to have complications, premature birth, and developmental complications. Among pregnant women taking psychiatric medications, benzodiazepines are more likely if people have panic and PTSD. They're more likely to use them if they've got polypharmacy. They're more likely to have alcohol and illicit drug use and less prenatal vitamin use. So again, when we look at these complications of the benzodiazepines, these increased rates of respiratory problems and increased rates of premature birth, is it really due to the benzodiazepines, or could it be due to some of these associated conditions? Again, a study by Dr. Yonkers, our moderator, has shown that women with comorbid PTSD and major depression have increased risk of premature birth and shortened gestation, and that's independent of medications. So the women with these comorbid conditions who are usually quite ill are going to be more likely to be taking benzodiazepines. Benzodiazepines have been associated with medically induced preterm birth, and if you use benzodiazepines in late pregnancy, that has the highest association with preterm birth. And again, we don't know if that's because people are developing medical illnesses that require them to have preterm birth, say eclampsia or preeclampsia, and they're very anxious about that, and they're taking benzodiazepines. It's really Very hard to tease out these factors when you have so many things that interact with each other and influence each other. If we look at benzodiazepines during lactation, again, as just an example, this is similar to the amount of data we have for other psychiatric medications during lactations. We know benzodiazepines passed into breast milk, and the little bit of data we have, infant serum levels seem to be low or undetectable. So even though the benzodiazepine drugs are getting into breast milk, they don't seem to be getting into the infant serum. But again, we're talking about case series here. In one study of 10 infants exposed to clonazepam during lactation, the levels were undetectable in 9 out of 10 infants. One infant had a very low level, and there were no behavioral problems reported. Another example of a study is that they looked at 124 infants exposed to a benzodiazepine during lactation, and there were no behavioral problems reported. So this is really a very small amount of information, and these weren't systematically collected. So, but it's all that we have. So it's reassuring, but we really wish we had a lot more information. Just one note about vitamins and herbs. We have even less data on the risk or the benefit of taking vitamins and herbs during pregnancy. I think you really have to be concerned about potential contamination because these are not regulated by the FDA, and studies have found when they do look at these things, they can be contaminated with toxins. Melatonin has very little safety data compared to hydroxyzine or Benadryl. So that wouldn't recommend that people take that during pregnancy. And omega-3s have not been turned out to be very effective in controlled trials for mood disorder during pregnancy. So I think at this point we have a very limited role for these vitamins or herbs as a solution to anxiety or depression disorders during pregnancy. And one of the last things I want to bring up, it's so important, is contraception. Again, as I said 3 times already, almost 50% of pregnancies in the US are not planned. And these unplanned pregnancies have higher rates of tobacco and alcohol use, higher rates of depression, higher rates of intimate partner violence, preterm birth, and infant mortality. So we really, for our patients, want to avoid unplanned pregnancies. And I think, as the last 2 speakers have talked about, providing more care in OBGYN offices, this is the ideal place to address contraception. And we really want patients to be using contraception while we're working with them to develop, say, optimize their medication regimen or optimizing their psychosocial conditions for pregnancy. So in summary, the main points I wanted to make, that pregnancy really can be an opportunity to optimize treatment regimens for people to try psychotherapy and to reduce use of unnecessary medications. Want to emphasize the importance of planning for pregnancy, how that can make be so much more ideal if that can be done. It's important to use contraception while developing these plans and getting people both socially and medication-wise in the best shape they can for pregnancy. And finally, for women who do need to take medication during pregnancy, it's good to be realistic about the magnitude of the risk associated with the medications and point out the impact of healthy behaviors, the positive things, the things they can control and can help to help them have good pregnancy outcomes. And I just included some online resources where if you want to look up about individual medications, mothertobaby.org has fact sheets and that can be given to patients, and there's a patient phone line that they can call in and ask questions. LactMed that I mentioned describes the risks of different medications during lactation and is frequently updated. ReproTox is another online resource that you can get through a paid subscription. Womensmentalhealth.org is a sort of a blog out of Mass General that's organized by topics and is updated often and gives more of a narrative discussion of different issues or different medications, different alternative treatments. And then DART is another reproductive toxicology database that gives collects together journal articles on different topics of medication exposure during pregnancy. And then also, what can be really helpful to help us get more information is if women who are taking medications during pregnancy sign up for pregnancy registries. I just listed 2 here. They're both at Mass General. One is one for people taking anti-epileptic drugs, and another one is a registry for psychiatric medications. So patients can call these numbers and they go through a consent process, and then they provide information during and after pregnancy to the researchers. And I think that's it. So I have time for questions if anybody has any.
Hi. I'm trying to unmute this. It's not.
No, I just heard you.
All right, we have one question from the audience.
Okay.
Hi, I'm Emma Span. I'm at an adoption agency in Texas, and I work with birth moms. And I was listening to you talked about there's not that much information about benzodiazepines and how they affect pregnancy, and also that other information is limited as well. And I noticed you said that smoking does affect pregnancy. It can cause pulmonary hypertension and all that kind of stuff, but I didn't hear anything about marijuana, and that's pretty common in my line of work, working with birth moms. And I didn't know if that would fall under smoking, since it is smoking in general terms. One of my clients' doctors told her that there were no statistical effects from that, and I was just wondering if that, just like benzodiazepines, are limited as well in the studies.
Are you asking mainly about marijuana?
Yes.
Yeah, I think definitely just smoking, it would have those risks, but I think there have been a few guidelines have come out recently warning people not to use marijuana during pregnancy. At first, we used to think we didn't know anything, but I don't know those studies off the top of my head. Does anybody else, Kim, do you know those?
Yeah, the recommendations have not changed, that we don't recommend using cannabis in pregnancy. And if someone is using medical marijuana, the recommendation for the American College of Obstetrician Gynecologists as well as Pediatrics is to please discontinue use of those treatments. You know, one of the issues that is potentially problematic with regard to marijuana is that marijuana has effects on developing brains. And I'm sure Dr. Monk can speak about that a little bit more than I can. And, you know, we certainly see it in kids and teens and young emerging adults. So it's a concern with babies as well. And Catherine, do you want to comment?
Sure. And does it actually work? Am I on?
Yeah.
Wow, so cool. This is getting used to this modern technology. I guess I would say 2 things. This is certainly an emerging area of concern, and from a neuroscience perspective, it's just really beginning to be studied. But in the absence of safety data, particularly for the baby, the consensus is not to promote using it. And I find clinically the added question is the CBD products, and a lot of women using those, and those are even less well known in terms of, you know, effects on the pregnancy, but are becoming quite common. And so I think we really still have a lot to learn. And there is, as many of you may know, the NIH has just started a new initiative from the HEAL money. This is the money related to our opioid crisis. And the study is called the Baby ABCD. And so it's a baby version of a study focused on adolescent brain and behavior development. And this is going to be baby brain and behavior development starting in utero. There will be fetal imaging, which is something I've begun to do. Mariah Thomason is a leader in it. And one of the main questions is going to be exposures, certainly opioids, but also looking at marijuana with the state's laws changing. So I think we're going to be learning a lot more in the next several years. It's a great question.
Thank you. Yeah, I was also wondering, with the new studies that came out, where would I be able to find those?
You know, you can go to something, you know, and it's a little bit wading through some scientific jargon at times, but what's called PubMed. And that's a free source. Maybe you're already familiar with that. And you know, sometimes I get emails from people who they can't access the actual article. They're only seeing the abstract because of different agreements with journals. And I'm happy to download papers for people. But then you might find that a study, particularly on marijuana and pregnancy, it gets picked up by the press nowadays. So you might do some cross-looking by Googling.
Okay, thank you so much.
I'm just trying to see. It looks like, do we have other questions? Because I have a question. I'm wondering about, Dr. Altimus, your thoughts about using paroxetine in pregnancy for depressed women?
Yeah, so paroxetine, as probably people know, there's been some controversy about whether it increases the risk of cardiac defects during pregnancy. And some studies say yes, some studies say no. And so if you were starting from zero and we're going to pick a drug to use during pregnancy, definitely I would not choose paroxetine. What gets more difficult is if you've got somebody already who's been on it chronically, who has done well on it, and then unexpectedly becomes pregnant. Question there is, do you want to switch to something else during pregnancy or just stick with what works? And usually, again, this is up to the patient and the doctor working with them. Usually people will choose to stay on the paroxetine, you know, again, because that choice is supported by some studies and some prospective studies. But again, if you were planning for pregnancy, that would give you an opportunity to try to taper off or try to switch to a different SSRI. So.
Could I jump in, or it's Catherine, or do we have another question? That's okay, yeah. I think many of us have said the similar things, and I really appreciated, Marty, you're bringing up the idea that if you're tapering down from medication, you definitely need some replacement. You need some tools, you need something, not just go off cold turkey. That's not going to work. And I just wanted to bring up that we had a study come out a year or so ago where we do fetal neurobehavioral assessments. So these are very gross indices of how the brain is developing. And the women in the study uniformly had a major depressive disorder, and they were almost all of them on SSRIs, and actually euthymic. So their mood was very good in pregnancy. You know, they were stable, they were not depressed. And we didn't see, my mission to be brought on this study was to do some of the work that my lab does, or we can see differences in fetal development based on maternal depression. And so the task was, can you see that based on the medication when we're rather controlling for the mood because they all have the same diagnosis? And in fact, we didn't see any effects on the fetus. So that was extremely reassuring. We saw one minor effect, which was the SSRIs were associated with a slight uptick in fetal movement. And that's been seen before. That's not really a risk factor. It seems to be associated with a little more movement as in the baby, as a newborn, and then it dissipates. What was super interesting to us, and I think important and relevant to all three of our talks so far, and very much I think a segue to Rahel's work, is that these were well-resourced women. They were getting fantastic care, clinical care. But at 12 months, on average, the baby's rating on a cognitive behavioral assessment called the Bailey was actually shifted to the left. So they were lower on average, and this was not an at-risk sample. And what we surmised from this was that many of the women got to their depressions in part through trauma, and that in parenting a child and doing the kind of serve and return that helps that brain grow over the first 12 months, possibly not enough of that was happening, so that their mood, their symptoms were being well treated, but they weren't getting some of the psychosocial support or kind of interventions to help with how they deal with relationships, sadnesses from the past, to be able to really engage with this baby. So I am, again, making a plug that we think of all of our tools together, particularly when we're in the mother-baby period and the parenting demands are so intense.
Yeah, and that's really a separate, I think what you're talking about is a separate deficit or a separate
Yes.
problem from depression.
Yep.
So depression
Yep.
is worthless or hopeless, can't get motivated or get out of bed, but there's other sequelae of trauma that affect people's functioning, that not in those gross neurovegetative ways.
Yeah, and I would say there's probably, certainly overlapping common symptom areas, and we just need all these different tools to really help a woman and then her family be in a more optimal place. Yeah.
I hope I can have, I just want to contribute 2 factors as we discuss antidepressants and pregnancy, which is, first, I like your point, Marty, that for people who are pregnant, we want to avoid multiple different medications. So once they're committed to a medication like paroxetine, which just Paxil, which has a worse rap, if you will, than the others, it doesn't make a lot of sense, especially if it's like the second trimester, to switch to something else and have 2 exposures in pregnancy versus 1. Similarly, it doesn't make sense to do this cross tapering in pregnancy. It should be done before pregnancy. Because we do like to minimize exposures as if possible. We also like to minimize exposures to medication that we don't know a lot about. That's another sort of central tenet, if you will. I want to say, because I've done a lot of work in this field and contribute to the literature, there's a lot that's written on preterm birth and antidepressants. And I think that there is a strong association between the use of antidepressants in pregnancy and preterm birth. But I would emphasize that the preterm births that we see are late preterm. They are not early preterm. In other words, they're moms who are delivering at 35 or 36 weeks, not moms that are delivering at 28 or 30 weeks, which I think is a different sort of risk bucket than the moms who are delivering at 28 or 30 weeks. It's an epidemiological metric that is very, very commonly used. When we look at the difference between the date of birth in moms who use antidepressants and don't use antidepressants, it's between 3 and 5 days. So they fall into that bucket of preterm, but it's really a very small difference from women who don't use antidepressants. So anyway, I'll put my soapbox away.
And that's actually a question that reminds me of a question I wanted to ask Catherine. You had such a big drop in the number of male births in your stressed people. So when were they, I guess, passing away, these male fetuses? Are they disappearing? Are those very, very early?
Yes, I think so. And I know we probably need to turn this over to the questions, but absolutely, we think that, the women had a very, very early loss prior to entering the study and may not have even known they were pregnant. So this has been just, we are not the first group. There's been a change in it's called the secondary sex ratio related to President Kennedy's assassination, 9/11. So there's been findings like this before. And in evolutionary biology.
So a very early mechanism.
Yeah, I mean, I think they're just having a loss, but we think of these stresses, both the physical and the psychological, and I think we should keep this in mind with Kim's recent comment that, these, if you will, soft signs of physical stress, a slightly higher blood pressure, a worse diet. We didn't actually see BMI as one of the factors, but this is just sort of an overall, it's the allostatic load model of just all these indicators. This is stress gets under the skin for the audience who not familiar with that term, and the signs in many systems in the body indicating that there's too much load. So we think these are early losses, and that it's been going on for a while. And so the flip of a coin, when they're, in our study, they've, the flip of the coin, they are carrying a girl this time, and the pregnancy is maintained.
Yeah.
It could also be selection of male sperm. It's not necessarily a fetal loss.
Yeah.
You know, there are certain conditions where which will predispose a woman to conceiving via, you know, a male sperm versus, you know, a sperm that has the female DNA. But I want to move on because we have two other questions and
Sure.
yeah.
We have one question, and this will be our last question, and then we can move on.
Okay. Do you have it?
I can hear it.
Hi, Astrid, are you asking me for the question?
Yes.
I'm going to sneak in a 2-for-1 if we have time, because I want to raise two things for elaboration. First of all, thank you all, obviously, for the talk and for moderating it as well. We're really grateful and appreciative of all the great information. Two questions on two different aspects of intervention. One on the biological side, I'm curious whether data exists addressing longer term mood and anxiety outcomes in now children or adolescents or adults who were exposed to SSRIs in utero. And sort of while you're pondering that, and I see obviously Dr. Monk, this is not the first time you've considered this question. My other question is for some of those sort of tried and true interventions, psychosocial interventions like CBTI or behavioral activation. Obviously, you introduce a newborn into that scenario, and it becomes much more difficult for a woman to implement some of those interventions. If you could speak to some of the typical challenges and maybe some creative solutions on those fronts.
Marty, certainly, and Kimberly, if you want to take the meds one, and I may chime in, and then I have some thoughts on the second one.
Sure. You know, I think you alluded to this, Marty, that there isn't a huge literature on the effects of antidepressant use in kids who are exposed in utero. And you know, there are some, I would say that some of the studies, depending on who does the reporting, in other words, if parents are reporting effects versus the effects are the result of an independent body doing an assessment of kids, the results do differ. But at this point, I would have to say overall, the results appear to be pretty benign. Maybe some results suggest an increased risk of anxiety disorders in kids later on, but that can be confounded by the parents' genetic predisposition toward having them. But Marty, what's your sense?
You know, nothing comes to mind except this one sort of classic study by Myrna Weissman where she longitudinally followed women who had depression and was able to look at their offspring over the years. And she did have a paper finding that women that were treated, she had some women were treated for depression and postpartum and some weren't. And the ones that were treated, their children had less depression as they when they were older, you know, when they were adults. So I think that really argues for treatment versus not.
Was that with an IPT or was that with a psychopharm intervention? The Myrna Weiss study.
I think it was STAR-D data, right?
Yeah, I think you're thinking of the STAR-D data. They were,
Yeah.
and they weren't treated necessarily in pregnancy. That was not a pregnancy study.
That's true.
I think you're thinking over 3 generations. I mean,
Yeah.
I would jump in and say the studies that are out there on this psychopharm exposure in pregnancy and kid longer term outcomes, some of them are epidemiologic studies. Some of the ones that have had bigger impact have come out of Finland, and they do show that the children have an increased risk of ADHD and anxiety and depression. However, big however, per Marty's points, it's super hard to control for the many other factors, particularly that the women on meds, even when you try to do all this controlling, they got to their depression, as I was trying to say, through a different pathway, which may include more shared genes of risk. So that's an issue. Also, the postnatal environment and all the raising of the child, as I was just trying to say in our study, are not controlled in these epidemiologic studies. They're not examined. So again, as Marty said, we're not doing randomized controlled trials where we can assign one woman to this and one woman to that and really isolate the medication effect. So, and there's no doubt that we need to be assessing women and in a collaborative way, deciding, as Marty said, what's the best treatment for them. And it's really awful when the press has these screaming headlines, and that is what influences decisions. I know we really have to run. I'll just quickly answer your question that yes, certainly postpartum, and this really goes into what Rahel is going to talk about, but we do need to adjust our treatments, our psychosocial treatments, to take account of the baby. And there are interventions such as Mom Power out of Michigan, which very much involves the baby being involved, Circle of Security, Minding the Baby out of Yale, actually. And then we have an intervention called PrEP, Practical Resources for Effective Postpartum Parenting, which is for women at risk for postpartum depression, and we start in pregnancy. So I think you're going to be seeing more and more of these kind of interventions. We draw on CBT heavily, and that are taking into account that there's more than one patient.
Thank you.
Okay, why don't we move on? Are we ready? So now I'd like to introduce our next speaker, Dr. Rahel Briggs. Dr. Briggs is National Director of Healthy Steps. In this role, she's responsible for all aspects of the program's operations, financial sustainability, evaluation, and research, policy model enhancements, and professional development and training. She comes to this role after a successful career at the Montefiore Health System in New York, where she grew the Healthy Steps footprint from 1 to 21 practices, serving over 30,000 children annually. The Montefiore Healthy Steps model informed the rollout of Healthy Steps throughout the state of New York. Additionally, Dr. Briggs is the founder and former director of pediatric behavioral health services at Montefiore Medical Group, one of the largest integrated pediatric behavioral health services in the nation. She's the editor of Integrated Early Childhood Behavioral Health and Primary Care, a guide to implementation and evaluation published by Springer, and recipient of the 2018 Healthcare Delivery Award from the American Academy, or the Academic Pediatric Association. She's an associate professor of pediatrics, psychiatry, and behavioral sciences at Albert Einstein College of Medicine. Dr. Briggs completed her undergraduate at Duke and her doctoral work at NYU. So welcome, Dr. Briggs.
Great, thank you. Hopefully everybody can hear me, and let's see what you can see in terms of showing a screen. Can you see the slides?
Yeah, we can see a screen, but not the specific slides, and we see you.
All right. Let's show a different screen then. Let's move this over. And while we're doing this, y'all have been on this webinar for a long time, so hopefully everybody is stretching and moving around and not just listening to us sitting in one place. So let me try again and share a different screen and see how this goes.
Yep.
Yep.
Okay. But great. It's not the full screen for. It's your screen. I think you have to press the projection view. Yeah, okay, you're good.
Are we good?
Mm-hmm.
All right, let's get going. Again, stretch. I work from home, as you can see, so the big secret about working from home is that you're all business up top, but I've got like leggings on underneath, so I'm not going to stand up and stretch, but I encourage you to do so. As Catherine talked about, I'm going to talk about bringing this maternal mental health into the pediatric setting. So let me figure out how to move us forward and get started. There we are. So we'll talk a little bit about this pediatric setting and why it's actually, I think, one of the best places to approach maternal mental health, and really dive a little bit deeper on the impact of maternal mental health on infants and toddlers, talk about Healthy Steps as just one way to address this, and really how that theory of change works in terms of maternal depression. So the pediatric setting, I think Joy spoke about this, Catherine spoke about this, we've all talked about. The dirty little secret is if you want to find a new mom, she's at the pediatrician. And I want to say that I'm using pediatrics here very flexibly to also mean family medicine, nurse practitioners, anybody who provides well child care for young children. We all know that the rates of follow-up at that 6-week postpartum check are quite low, especially in low-income communities and some of the families that we are most eager to serve. And yet, did you know that depending on the data set you look at, about 90 to 95% of families regularly take their baby to the pediatric setting? 90 to 95%. There are 12 well child visits within the first 3 years of life, and those are really cohorted in that first year where you have 7. So what an extraordinary platform. It's our one universal platform. You've got this frequency of intervention. And of course, different than something like early childhood education, the parent is always there. There's no school bus that brings the baby to the pediatrician. This is always at least a dyadic, if not triadic, multi-generation visit that occurs. Then you have this idea about stigma and trust, and we've all talked about that, or the previous presenters, excuse me, have talked about that. When you look at surveys about who parents trust for advice or insight about parenting, pediatricians are the only category of people to break into the top 5 usually, and everyone else in the top 5 are family members, spouses, parents, other folks. So you've got this trusted, almost universally accessed, repeatedly accessed system that is, I know the slide says non-stigmatizing, but as a child psychologist myself who worked a long time in the regular mental health field, I'd go one better than that and say positively stigmatized. Honestly, almost no matter your cultural or your ethnic background, you're a good parent if you take your child to the pediatrician. So really a pretty extraordinary platform, you know, to bring in this parental mental health. So what's the problem? Well, as Joy very accurately described, pediatricians have very little training and experience addressing mental health concerns in their patients. That is a little bit different for family medicine docs, I will say, but the vast majority of children are seen by pediatricians, not family medicine docs. Pediatricians historically don't view parents as their patient. The baby's the patient. The baby is who's in the electronic medical record, and they went into this to work with kids, right? Similarly, parents might not think about the pediatrician as a source of help for their own needs, despite the fact that that parent is seeing that pediatrician again 7 times in that first year of life. And I don't, you know, when did all of us go for our last well check? Of course, there's the stigma issues and there's the concerns about child protective services, but research shows over and over again that if asked, parents will confide in their pediatricians about depression. There's less research about anxiety, and so I'm talking more about depression here, but if asked, parents will confide. So then what do you do about this? Because pediatricians, again, I've had pediatricians say to me, they invoke ethics. They say, ethically, I can't see this mother. I can't treat this mother. I can't even support you or our practice asking this mother about her depression because that's outside of my scope. So when people start invoking ethics, you know, you tend to take a back seat. But the good news is that when you bring in integrated behavioral health, where a behavioral health provider works alongside the pediatrician, either in the Healthy Steps model or another model, that changes. So one pediatrician in particular who said to me, and I quote, "Rahel, over my dead body, will you screen for depression in this pediatric practice?" 18 months later was doing universal screening for depression because we brought in those integrated services. So I think that's a really key piece of this. We can't ask pediatricians to go far outside of their scope of practice without giving them those important supports. I'm going to spend literally 2 seconds on this. Everyone has talked about this. I don't think we need to go over it. But I am going to go into, we've talked about impact on mother, but I want to spend some time about impact on child. And so obviously we're talking about gross mean averages here. We're not talking about this is guaranteed to happen, but we do know that depressive episodes can affect parenting practices. We know that it, as folks have said previously, we know that there's increased risk for non-initiation or just stopping breastfeeding. We know that there's risk for not getting that medical care for children, so maybe not making it to those 7 visits in the first year of life. A lack of safety and parenting practices at the far end of the spectrum, child abuse and neglect, adverse child cognitive and emotional development, and impaired parent-child relationships. So let's take those last two and dive a little bit deeper on those. And as Catherine said, sort of what's going on here in terms of that serve and return, how that gets interrupted, and the impact that has on that critically important early childhood brain. So when we look at maternal depression on child outcomes, we think about this. We think about serve and return being the really fundamental mechanism by which the environment impacts brain architecture. So what do we mean by serve and return? There's some great video of T. Barry Brazelton, who recently passed away, but was a well-known pediatrician, where he says, serve and return is nothing more than when the baby says, ooh, and you say, ooh, back to the baby. That's the most basic form of serve and return. The baby has served up an ooh, and you've returned that ooh. And that actually goes toward building the very architecture of the developing brain. The first 3 years of life are a massive time of brain architecture and structuring decisions. Jack Shonkoff very famously says that age 3 is middle age when it comes to brain development. And what he means by that, of course, is that so much activity happens within these first few years of life. It is the most sort of disproportionately receptive and important time of brain development. And that's why your 2-year-old can learn Spanish in 6 months, and you're still stumbling through hola, ¿cómo estás? But it's also why your 2-year-old who's exposed to 6 months of serious parental depression is at disproportionate risk. And that's a really important thing to understand. So what's happening when you have, say, maternal depression in the serve and return? Potentially, there are two sort of ways it can go. That serve and return can either be seen as the child as a little bit withdrawn. So baby serves, baby gives up that ooh, but doesn't get a return back. And I'm sure a lot of you have seen the still face experiments by Ed Tronick that really masterfully demonstrate that. In addition to just that withdrawn sense, serve and return sounds quite simple, but it requires good timing. It requires contingency, things that can really suffer when a parent is depressed. And so then you get to this sort of impaired emotional regulation of the baby, because of course baby doesn't regulate on his or her own. Baby regulates in relationship to a primary caregiver. You get increased potential exposure to toxic stress, and then that can lead down the road, because of this disproportionately important time of early childhood brain development, to behavioral cognitive functioning concerns and success in school. Another quote from Jack, he says, as young children develop, their early emotional experiences literally become embedded in the architecture of their brains. And folks talk about it almost as emotional tattoos that don't go away. That early childhood brain, it's like a sponge. It picks up the good and the bad, but it picks it all up. So with all of this, we tend to then focus on, then we've got to make sure that especially very young parents of very young children have the accurate supports that they need. And so one solution to that, and as I mentioned earlier to the questioner from Baltimore City, and what I'll spend the rest of my time talking about, is Healthy Steps, or bringing in some level of integrated pediatric primary care, right? And we do have Healthy Steps practices right in Baltimore City through the University of Maryland. I've had the pleasure of visiting them. And interestingly enough, they are in a family medicine practice in Baltimore City. And one of the things they're doing is that they're enrolling families right at conception. And they've shown some really exciting impact on maternal depression based uniquely on the time of enrollment. So the earlier in the pregnancy that the family is enrolled in Healthy Steps, the lower the likelihood that the mother will ever have a positive score on the Edinburgh. So happy to share that with folks. It's not in these slides, but it's not published yet, but I do have some slides on it as they're working on it. So what is Healthy Steps? Again, just the integration of a new person into the pediatric primary care team. That person is called a Healthy Steps specialist. Around the country, the vast majority of Healthy Steps specialists are either licensed clinical social workers or doctoral level psychologists. And they're partnering with the pediatrician to focus on positive parenting and healthy development for babies and toddlers. We have a 3-tiered service delivery model that simply tries to be, on the one hand, universal and practice some real population health activities in tier 1, and then have a risk stratification so that our most at-risk families receive the most intensive level of services. We have 8 core components, and you'll see that that second core component is that we require universal screening for family needs, including maternal depression and other risk factors that largely fall under the social determinants of health. If a practice is going to be a Healthy Steps practice, they must screen universally for maternal depression. They can use either the PHQ 2 or 9 or the Edinburgh, and Joy went through both of those screens. We don't care which, but you've got to screen for maternal depression, and you definitely have to do it within the first 6 months of a baby's life. So everybody in the practice, all families with all children birth to 3 receive those universal services in tier 1. And that's an important antidote to stigma, right? The more universal that you can make your screening, the less that you've picked out a certain parent in a waiting room, the more likely you are to be successful. Moving up the risk stratification, some children and families receive everything in tier 1 plus some short-term consults. We like to say these are for light pink flags, not red flags, but the earliest possible warning sign that something's not going perfectly, and the Healthy Steps specialist will come in and meet with the family. Lots of care coordination and systems navigation. So the big piece there is connecting parents to needed services in the community. A heavy, heavy focus on positive parenting guidance and early learning resources. And then finally, for our most at-risk families, which practices can define however they'd like, and certainly parental mental health concerns would land you in tier 3. You receive all those services in tiers 1 and 2 plus. Remember those 12 well child visits that I mentioned in the first 3 years of life? The Healthy Steps specialist is co-managing those alongside the pediatrician. The next slide just shows those same 8 core components in a different way, but it's exactly what you saw before. Healthy Steps had a randomized control trial that was a national randomized control trial back in the 90s and early 2000s, and you see a boatload of probably hard to read small text pieces of evidence here. These are available on our website from healthysteps.org, the evidence, and you can download this. But I will highlight under child health and development, really showing the impact. Catherine talked a little bit about trauma and the way that trauma can overlay or also be involved in depression. We have found that for mothers who report childhood trauma, their children do better in terms of social emotional development if they receive Healthy Steps versus a comparison group that did not receive Healthy Steps. We've also looked at greater security of attachment in terms of children and child behavior problems. We've looked at referrals out to the community, breastfeeding, child safety. In parenting knowledge, a lot less likely to rely on harsh punishment or use severe discipline. Better understanding of infant development. And then you see, and I didn't just make this for this webinar, a whole chunk of data that talks about the impact on maternal depression. So over and over again, finding that when you bring in Healthy Steps, mothers are more likely to discuss their symptoms when they have depressive symptoms versus when you don't have Healthy Steps. They're more likely to get referred out. Providers are more likely to discuss postpartum depression with mothers. Again, thinking back to that pediatrician who said to me, over my dead body, and then after 18 months was universally screening for maternal depression. That was because she felt like she had backup. And then finally, a very exciting finding where they actually tracked symptoms and showed that those depressive symptoms reduced after just 3 months in the program. So lots more on the evidence, but I won't spend too much time. I do want to walk into, and this is a pretty wonky and busy slide, but I just want to talk briefly about Like, what's the theory of change here? How is it that you'd intervene in a pediatric practice and that impacts something like maternal depression? The way we think about it is we think about factors modifiable by a program like Healthy Steps and factors that are potentially non-modifiable. I will give the caveat that for some of those non-modifiable ones on my right hand of the screen, maybe your left hand, change when you enroll prenatally, right? Like that Baltimore City family medicine practice that I mentioned earlier. But the biggest things we think we can impact are support from spouse, partner, family, friends, social isolation, alcohol and drug use, postpartum smoking. And how do we do that? Well, through that universal screening, through the on-site consultation with the Healthy Steps specialist and any additional integrated behavioral health providers on site, and to successful referrals of mothers to off-site services, but successful being the key word there. We all know that we've created a system that, for better or for worse, requires a professional to navigate it. So this is not just giving mom a piece of paper and a phone number and saying call them and they can maybe help you. This is really doing a very critically warm handoff, not cold handoff, as Catherine talked about. And we have some great data to show that these referrals, when they're managed in this way, really are much more successful than the just sort of, here's a phone number and best of luck to you. We also think about strategies and whether or not it's something that we at the national office are promoting. Those are those little blue babies. Something that's already happening at the Healthy Steps sites, but we're not requiring it at the national office, or something that's been effective in the literature, but we're not quite doing it yet. So the one that's been effective in the literature, but we're not quite doing it yet, is whether or not we can actually train the pediatricians themselves in behavioral change therapy or IPT. I have nothing but respect for pediatricians. I have spent my career being a guest in the pediatric medical home, and I think that they are some of the best people around. I have had the pleasure of working with really committed pediatricians. You don't go to Montefiore in the Bronx if you just want to make a lot of money. You go because you care about social justice, you care about social determinants of health, and you care about the community. And I'd say I could count on one hand, after doing this for about 15 years, how many pediatricians would actually go through an interpersonal therapy IPT training course. This is not their lane, it's our lane in the mental health world, and we need to do a much better job of integrating with them rather than asking them to do this on top of everything else they're supposed to do, by the way, in their 15-minute visits. So what do we ask our Healthy Steps specialists to do? There's a list here, but this is part of their charge for those tier 3 families. So remember, they're seeing those tier 3 families 12 times in the first 3 years of life at a minimum, and potentially even more, because of course you can come back beyond those well child checks. Lots and lots of things that the Healthy Steps specialist can do. I'm going to skip this video because I don't think you're going to be able to hear the sound on it, but hopefully you can access it, and if not, I'll make sure to get that to Astrid. But it's an in-action example of really showing you how during a well baby visit, the Healthy Steps specialist is talking to mom about her depression, walking her through some deep breathing so that they can think together about what the next steps are and how she's going to access needed services. Oh, can you hear it?
Yes, we can hear it.
Okay, great.
Healthy Steps is a wonderful integrative care model that allows and brings the Healthy Steps specialist in alongside the pediatrician. But sometimes the pediatrician goes first, sometimes we go first. It all depends on the nature of the visit.
So I know we've talked a lot today, and as you have a lot on your plate and a lot going on, we have Healthy Steps here to help us talk and get into more details with a lot of the things that you have going on in your life. But are you okay if I left you another time here to talk?
Is that okay?
Okay, awesome. It was great to see you.
Take care. Thank you. So in the room, I have an opportunity to talk not only about developmental milestones, but any concerns that the parent may bring. And the last time that you hear, because I know I shared with you, there were a lot of visits missed. Yeah. Right? But the last time you were here, that was the concern that we had, just in terms of getting you support.
Yeah, the post-traumatic depression.
Yes.
I know.
And you're expecting now.
Yes. I just found I was pregnant 2 days ago.
Okay. So there is a lot. So if there would be one thing that you would need support with today, what would that be for you?
It would be like getting my kids to it with their WIC, their shots, so I can get them daycare.
Yeah.
A big part of my stress is not being able to get my kids situated the way they should be.
It's the full system that we are supporting and looking at. We're asking moms, what are the successes and what are the challenges? And those challenges may be around housing. The challenges may be around finding a right daycare. It may be around food insecurities.
It's a lot of stuff going on.
Right. So it's overwhelming. So what are you doing during the day?
Right now, I'm at home, full-time mom. Like, I can't.
Taking care of the babies.
Yeah, and then it's like, because of the depression, I'm so lazy and so tired and don't feel like getting up to do anything, that it's like, it's putting me behind.
By being present and again, doing parental mental health in a pediatric setting, a one-stop shop where you're here for your baby, but also for yourself. Because what we say to our moms, you have to put your oxygen mask on you first in order to be present for your baby.
It's like I had like these weird breakdowns. Like last night I was just laying in the bed and tears just kept rolling.
Yeah.
Rolling down, like they wouldn't stop. It was like, what am I crying for? But it's like, it's not just one thing, it's so much stuff.
Sure.
It's like impossible.
Sure. And so you get overwhelmed.
And then it causes me to snap at the people around me that care about me, like my fiance. Little things he do get under my skin so bad. It's like it's not even that it's him. It's just like everything else.
Yes. I'm asking questions about you. How are you doing? What are the things that you're facing every day? And we could schedule time so that you could come back next week.
Okay.
Does that make sense for you?
Mm-hmm.
Okay. All you have to do is be in a space with a mom, with a newborn parent, or even if you're a seasoned parent. Every baby and every experience is different. And it's not going through a trajectory of questions that I have to answer, but I am listening to what you bring into the space at that moment for this session.
So it's a beautiful example, and then I'll read this to you because it's a lot of words. And I just want to say quickly, if I do my job right, Healthy Steps goes away as a program, and this is just standard of care for pediatrics. You're going to hear Healthy Steps from me over and over again. It's one way to integrate behavioral health into pediatrics. It's a big tent, it's a big table. We all need to work on this, but this pediatrician is talking about Healthy Steps. So she said that our Healthy Steps specialists are providing our practice with much needed resources that we didn't have access to prior to implementation. We've had multiple moms identified with symptoms of postpartum depression through the universal use of the Edinburgh. Several of these mothers would not have been identified without these questionnaires because they denied symptoms verbally or they appeared to be doing well on the surface. Thankfully, now when a mother is identified as high risk for postpartum depression, our Healthy Steps specialists are available to provide excellent support, detailed resources, help her connect and get the help she needs. One mother ultimately decided to start taking an antidepressant as prescribed by her doctor after meeting one of our Healthy Steps specialists. This mother indicated she had not been planning to start this prescription until after working with the Healthy Steps specialist, and since starting the medication, this mother reports great improvements in her symptoms and her baby is thriving. This is a success story that might not have occurred without our Healthy Steps team. Our practice is so thankful. We found it to be invaluable. We're not even a year into implementing the program and we already can't imagine how we did it before. Healthy Steps is filling a void of services, and we've come to depend on the program for the wonderful support it provides for our patients and their families. So I know people think, well, pediatricians should do this or they should get started doing it. It takes team-based care to do it well. So thankfully, our plan is to try to cover more than 1 million children with Medicaid by 2032. We are on our way. We're currently in 161 sites in 21 states, DC and Puerto Rico. Next week, actually, we'll be coloring in the state of Alabama, which I'm excited about. And in December, also the state of Mississippi, which I'm very excited about. Really on our way to, as I said, serving over 1 million children a year by 2032. We think that this is where you should reach children. Where there are babies in pediatric practice, there are families. And there's something about that critically momentous time in a family's life where they may be open to making some changes and doing some improvements that they weren't open to before. You have this window when a new baby is born to stop smoking maybe, to start taking the antidepressant maybe. And we hope that we can partner with pediatrics so that that can really happen. So thank you, and I will take questions.
Oh, there. Thank you so much, Dr. Briggs. I think we have time for a few questions. As a reminder, you can still submit questions through your chat box or in the attendee control panel. You may be invited to read your questions aloud if you have a mic. I have a question for you, perhaps to begin. If you have a mom who, or maybe you see a dad and a mom, but the mom is very depressed and she has tried to do what she can do to treat her depression, but she's still depressed. How do you allay her concerns that her illness is somehow causing damage to her child?
That's a great question. And I think we all know that, that there's a lot of shame in depression and shame about the role you're playing and the job you're doing as a parent. There's some wonderful research that comes out of Beatrice Beebe's lab that talks about the % of time when parents and infants are actually engaged in that really contingent, matched, serve and return type of interaction. And the research suggests that it's only about 30% of the time that happens, rather than everybody thinking, I've got to be on 100% of the time and be doing the serve and return and oohing and ahhing with this baby the whole time. And it turns out that if you can do it, you know, as a baseball player, if you can get on base 1 out of every 3 times, if you can do it, you know, we start with 5 minutes a day. 5 minutes a day of floor time where there's an attempt to really be present with that baby. Maybe the next week, right? And really start to build that system. Also really recognizing that without treatment, we don't expect moms to suddenly feel better and be the kind of parent that they want to be. And really putting that first and foremost in terms of our importance. And you know what, if you're not reading to baby this week because you're just too darn depressed, then that's okay. We'll get to the reading. Let's work on getting you access to the treatment that you need first.
So maybe the scar analogy is imperfect in somehow, because that sort of suggests that this is something you can't remediate.
When you say the scar analogy?
At the beginning of your talk, you were describing how stress to the baby is a scar that they carry forward in their brain, kind of like that.
Right. So toxic stress is defined as chronic, unrelenting stress that is not mitigated by a caregiver. So the word chronic and unrelenting is really important there. And I think that, you know, the sad truth is that, yes, if mom was severely depressed for the entire first 3 years of this baby's life and there was no other primary caregiver to intervene, we could have some significant challenges. but that chronic word is important, right? And if it's not for the entire first 3 years of baby's life, and there is treatment and there is improvement, that plasticity of that early childhood brain works in both sides, right? When we talked about learning Spanish or being exposed, it's plastic in all directions. So when you watch those still face videos with Edtronic, where mom is really, really still faced and the baby sort of gets very disorganized and really is trying to get her attention, the second that she comes back to life, so to speak, and is animated, the baby sort of perks right up, right?
Good. Okay. I just want the listening audience to know that it's not simply the fact that permanent damage has been done if a mom is depressed when her baby is born, and that,
Absolutely.
you know.
Absolutely.
Thank you for a wonderful talk. Do other people have questions?
Hi, my name is Kaylee, and I had a question about funding or sustainability of the program. So I work in a pediatric office and we're screening all the moms, but having difficulty connecting them with treatment. And I'm curious how Healthy Steps is funded or reimbursed typically by the clinics that have implemented it.
Great question. That's a whole nother segment of a talk that I often give, but didn't include here, but it's a great question. So a couple things I will say before I answer the question specifically. I hope everyone knows that CMS put out a guidance document in May of 2016 suggesting that the gold standard treatment for maternal depression would be to provide a dyadic treatment to the baby and the mother and to bill it to the baby's Medicaid. So that's really important. It was the first time ever that the feds came out and said, you know, the resistance had been, well, that the baby's not the patient, mom is the patient. How are we going to bill baby's Medicaid? And finally, CMS in May of 2016 really came out and said, this is absolutely what you should be doing. This is the gold standard of treatment. And so almost all states at this point have some mechanism in place to pay for maternal depression screening in the pediatric office. So that's important. Of course, when federal guidance comes out, it's just that. It doesn't mean that the state has to do it, but it's at least it removes that ability to say, well, that's not our patient. So I wanted to make sure everyone was aware of that. In terms of how Healthy Steps is funded and paid for, it's an excellent question. We live in a world that pays for things based on a diagnosis, right? And if we do our job right in Healthy Steps, the baby may never have a diagnosis. So there we are. We largely rely on philanthropic dollars to get started. And then we have had some success in terms of a certain set of billing codes, and I'd be happy to share those with you. I'm sure Astrid has a way to connect us. We've got a lot of documentation around sustainability and how those Healthy Steps practices get sustained. What tends to happen is that some philanthropic dollars will start the program, and then the health system simply decides to do health system reinvestment to keep it going because they see the actual short-term cost savings. We're not just talking about the usual long-term cost savings of when we intervene with babies and toddlers, but short-term cost savings, some on the child side and some on the adult side in terms of birth spacing outcomes, smoking cessation outcomes, interpersonal violence referrals and improvements. So in a lot of our biggest health systems, it's been health system reinvestment. That's the case, for example, at Cincinnati Children's, at Montefiore in the Bronx, and a number of other systems where they've decided that they're just going to pay for this. It's a relatively inexpensive program. For those tier 3 families who receive the most comprehensive level of services, the average costs around the country are $450 per family per year.
Yeah, thank you so much for answering that question. I'd love to connect with you afterwards, so I'm sure they'll have your contact information listed.
Absolutely. It's rbriggs@0to3.org, all spelled out. And the good part about having a funny name like Rahel Briggs is it's usually me if you Google.
Thank you.
Sure.
Do we have other questions?
Yes, we have one more question.
Okay. You can go ahead, whoever has a question. Oh, okay. I'll read it. Do the parents need to be registered as patients in the pediatric medical record system? Where do funds come from to pay the embedded Healthy Steps providers?
Right. So I think the second question I just answered a little bit from, but it's a great question on the first one. So when that CMS guidance came out in May of 2016, a bunch of pediatricians and the American Academy of Pediatrics said, well, hold on a minute. We're not going to document maternal depression scores in our medical record. This is the baby's chart. This is not mom's chart. And the official guidance from the AAP is that aspects of, I'm not quoting this, but it's something close to, aspects of the parent's well-being that are relevant to the care and well-being of the child should and can be included in the child's record. So you can interpret that in a number of ways, but in essence what happens is, no, you're not requiring that the parent be registered as a patient unless they're receiving their own parental mental health treatment as part of the program. If they get to that parental mental health treatment that is that embedded integrated psychologist in pediatrics, then yes, they need to be registered as their own patient. Everything short of that is documented in the baby's chart under that sort of guidance that if there are parental characteristics that are important to the care and the well-being of the baby, they can and should be documented in the kid's chart.
Great. Okay. I guess that's it for us. I want to thank everybody for participating and for attending ADAA's first virtual fall forum. You will receive a follow-up email shortly that includes the link to the webinar evaluation, the webinar recording, and post-test assessments for those that are seeking some CE credits. Please stay on the webinar platform if you'd like to take the post-test assessments after a few announcements.
Awesome. Thank you so much, Dr. Yonkers, for moderating this event.
Thank you.
Like Dr. Yonkers said, you will receive a follow-up email shortly that will include the webinar evaluation, recording, and instructions for CE credits. Please stay on the webinar platform for a few announcements. Thank you, Dr. Yonkers.
You're very welcome. Have a good day, everybody.
Our next ADA Live webinar, State of the Science Interventions for Anxiety in Older Adults, featuring Dr. Julie Witherall, will be held on Thursday, November 7th at 12 p.m. Eastern Time. If you'd like to register, please visit adaa.org. We would also like to invite you to register for ADA's 2020 40th Annual Conference. ADA's conference will bring together an expected 1,400 clinicians and researchers from across the U.S. and around the world who want to improve treatments and find cures for anxiety, depression, and co-occurring disorders. Choose from 160 plus sessions, hear engaging plenary speakers, learn about cutting-edge thinking in research and clinical practice, and earn CEs and CMEs. You will receive a discount code in the follow-up email for a discounted registration fee. On behalf of ADAA and all of our presenters, we thank you so much for joining us today.